For today, I am in Tirupati. You are in.
Three, two, one. We are live now, ma'am. We can start.
Thank you. Thank you.
Good evening, everybody. Myself, Dr. Vishal Dave, gynecologist and medical advisor to Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this 34th episode of Synergy on the topic ultrasonography in gynecological pathologies. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal OBGY Society. She is founder-president of ISOBOP chapter of Bhopal. She is national executive member of ESAR. She is joint secretary cum joint treasurer of MPIAG, coordinator of Foxy Infinity Committee. She was convener of ESAR Perfection Series, Foxy Symbiosis Series, and the convener of the present the Synergy Academic Club. Over to Dr. Monica Singh.
Thank you so much, Dr. Vishal, for that generous introduction, which is actually not required. And I think in the process of designing this webinar in the series, I have connected to so many dignitaries of Andhra Pradesh and Telangana that it's like a reunion today. And the focus is not only a social sort of virtual gathering, the focus is academics, very high quality academics. So we present in front of you the 34th episode of Synergy, which has synergized today with 30 societies of Andhra Pradesh and Telangana. The participating societies are 17 from AP, namely Anantapur, Chittoor, Guntur, Kakinada, Vishakhapatnam, Nandyal, Angul, Rajamandri, Tirupati, Nellore, Prodatur, Srikakulam, and Vijayawada. In Telangana, we have got 13 participating societies, namely Bhadradri, Jagtial, Khammam, Mehboobabad, Mehboobnagar, Kurutla Medpalli, Karimnagar, Hyderabad, Mancherial, Nizamabad, Warangal, Nalgonda, and Siddipet. We welcome the presidents and secretaries of all these 30 societies, and we are honored by your gracious presence. Today, we are dealing with a very interesting topic which never goes out of fashion, that is ultrasound in gynecological pathologies. Since ultrasound in obstetrics is a very, very huge topic, today I just wanted to limit myself to gynecological pathologies, and for that, we have a stalwart, a star speaker, and a star moderator. We will be introducing our dignitaries, our chief guest, our guests of honor, the special guests, our stars of AP, our stars of Telangana, my coordinators, my co-convener. So before we start our formal felicitations virtually, let us walk you through the scientific program. We have a 1 hour lecture, a keynote address by Dr. Sonal Panchal. She is an authority on this subject, a writer, author, innovator in ultrasound, I should say, who will scan the spectrum of gynecological pathologies on ultrasound. She will deliver a comprehensive talk. And next, we have got a Q&A session where you can ask your doubts, even related to knowledge, you can ask your doubts. And then we have a very interesting session by Dr. V. Jayabharti, ma'am from Bhadrachalam. Madam has been in our programs before, and she was so popularly received and so much praised for her, her all-inclusive type of panels where she makes things very interesting. The focus shifts from question and answers to a general discussion, which takes your knowledge to a different level. So, ultrasound and Mullerian anomalies is her topic, where she will walk us from confusion to clarity. And this panel discussion will have panelists from all over AP and Telangana, who are all good friends of mine. Before we wind up, we will announce the date of our 35th episode. So, with all humility, I graciously welcome our chief guest for today, respected Dr. Shanta Kumari Sekharan ma'am. Madam is the past president of Foxy and past treasurer of FIGO. She has held all important posts in various organizations besides being the leading figure in OGSH, which is the popular name for the Hyderabad OBGY Society. She's also been active in the Sri Lankan OBGY societies. She is a senior obstetrician gynecologist laparoscopic surgeon at Yashoda Hospitals, Hyderabad, has organized some wonderful conferences, has been awarded lots of lifetime achievement awards, FRCOG honoris causa, and is a keen academician. And Madam has met me recently, extended her blessings to the program. So we can just thank Madam and move to the guests of honor. Our guests of honor for today evening are Dr. B. Aruna Suman, who is chairperson of Foxy International Academic Exchange Committee. Madam is a very good teacher. She is a renowned teacher and leader, and she has worked in Foxy for decades altogether. We know her as the very active joint secretary of Foxy in 2021 with Shanta ma'am. And she has been a key figure in organizing wonderful conferences in the city of Hyderabad. She's been very active in the No to Violence Against Women Committee, Practical Obstetric Committee. She is a teacher par excellence at Medical College Jagtial, Telangana. Been awarded several awards, done several publications, and the key awards given to her are the Dhira Award, Foxy Achievers Award, IFS Excellency Award, and Award for Excellency ISSS RF. We welcome Dr. B. Aruna Suman as the guest of honor. Next, I would like to welcome our guest of honor, Dr. R.S. Ramadevi, Madam. Madam is the retired Director Medical Education of the state of Andhra Pradesh. And every time I have called Madam, she has received the phone very promptly and been very encouraging about the whole episode and the way we went about it. So, Dr. Vishal, if you want, you can call Madam once and remind her. So,
Yes.
yes, she's been a luminary figure in the field of OBGY in the whole of Andhra Pradesh and worked as a principal of Siddharth Medical College in Vijayawada. She is a mentor, teacher, and guide. She told me the names of so many students of hers who are taking part in today's webinar. She is the founder president of Andhra Pradesh OBGY Society, which just had its annual conference in Angul. She's led Vijayawada OBGY Society as president for 9 terms. We welcome Madam amongst us as a guest of honor. Next, we would like to invite our guest of honor, Dr. Susila Pinamaneni ma'am. She is a senior gynecologist in the city of Vijayawada. Madam is having the 25th anniversary of her hospital today, so she is not able to join. She's extended her blessings to us. And last but not least, we have got Dr. Radha Tatpudi ma'am. You all must be knowing her so well. She's always talked to me very nicely. At present, Madam is in the US, so she will not be able to join. And she is also a person who is really looked upon too as a mentor and teacher in Andhra Pradesh. So we thank all our dignitaries and we move to our special guest for today. Our special guests are Dr. Shashi Prabha, Madam. She is the past DME in the state of Andhra Pradesh and the past principal of Andhra Medical College. We welcome Madam. Next, we have a special guest, Dr. Chinmay Ratha and Dr. Kiranmay Devineni. Both are past chairpersons. Dr. Chinmay Ratha is an expert in fetal medicine, and she was heading the perinatology committee for 3 years as chairperson. At present, she is the director of Resolution Fetal Medicine Center and Research Institute and senior consultant fetal medicine at Yashoda Hospital, Hyderabad. We thank Madam for her support. Dr. Kiranmay Devineni has been the past chairperson of Foxy No to Violence Against Women Committee. No to Violence Against Women was a clause which was first coined by Dr. Shanta Kumari ma'am, and Dr. Kiranmay has led this committee very ably for 3 years, and we are waiting for her to become now vice president. Next, I would like to invite our stars of Andhra Pradesh, Stars of Andhra Pradesh and stars of Telangana are the figures, the visionary figures of the state who have led the state from the front and their societies in a very distinctive manner. And you can associate the state with their names. So we have with us Dr. Yashodhara Pallam Reddy. She is the founder president of Nellore Menopause Society as well as Nellore OBGY Society, a keen laparoscopic surgeon, graduate from Tirupati and postgraduate from Gulbarga Medical College, and also a social activist. So I think Madam is there with us. Yashodhara ma'am, would you like to speak a few words?
Yeah, thank you so much, and wishing you all the best for your today's program. Honestly speaking, I'm a big fan of Dr. Sonal Panchal. Yeah, so I'm really interested. Right now, I'm traveling to Bangalore on the way, on the way to Bangalore. Thank you.
So,
Yeah.
ma'am, what do you think of synergy? What do you think of this concept of doing a program with the societies and then inviting? Would you like to suggest something
It's,
to
it's
make it?
really interesting and it's really good. But only thing is, a lot of webinars are going on, and so that's why people are not part of it and people are not interested. Conferences also really same thing is happening. Yeah, as you said, recently we had Ongol conference. So in Ongol conference also, I even me and Apurva, we were there on Sunday. They made beautiful arrangements and talks were really so good, but attendance was not that much expected. Actually, I missed the workshop, so that's how things are going on. Maybe because too many are there, that's why attendance is becoming poor.
Yes, ma'am.
Uh, yeah.
Physical conferences, very rightly said, have got a different set of problems, and
Mm.
webinars have got the risk of becoming monotonous and repetitive, and sometimes substandard. So you're very right. You have to keep a right balance in order to take your academic acumen forward. Thank you so much for joining, Yashodhara ma'am. And now we have our stars of AP. Vishal, can we go back to the slide? We have the star of Andhra Pradesh with us, Dr. Captain Sheshasai Tirupati sir. Sir is the president of Chittoor OBGY Society. I have been interacting with sir since a lot of years. He is an alumnus of the Armed Forces Medical College in Pune, which is a renowned medical university. Subsequently, he worked in the army for 5 years and then worked as professor at Government Maternity Hospital and SV Medical College, Tirupati. Presently, he's working at Sukanya Hospital, Tirupati. He is also the Family Planning Commissioner for AP Government, a recognized laparoscopic surgeon and a teacher. We welcome sir. And Sheshasai sir, are you there? Okay, so we will ask for him to speak when he comes. And Dr. Venkateshwara Rao is President Guntur OBGY Society. He is also the star of Andhra Pradesh for today. Next, we would like to welcome the stars of Telangana state. We have got two eminent leaders from the city of Hyderabad. Dr. Ananta Lakshmi Paga, who is leading the OGSH from the front as its able secretary, and Dr. Jamna Devi Ji, who is senior consultant at Yashoda Hospital, Hyderabad. She is very active in the Indian Menopause Society, where she holds a senior post, and she's also been the past treasurer of OGSH. So next we start our felicitations or not our formal felicitations of the president and secretaries of the AP and Telangana societies. We start with the 17 societies of AP, and I'll be taking your names and thanking you. If anybody wants to speak, please feel free to do so. This is your program, and you can speak whatever you want about the program, about the topic, or any improvement you would like to suggest. From Anantapuramo Society, we have got President Dr. Shamshad Begum Sheikh and Secretary Dr. Nisi Vinutna K. We thank them. From Bhimavaram OBGY Society of AP, we've got President Dr. Narsavani Sunkara and Secretary Dr. Jagdishwari R. From Chittur OBGY Society, we have got Dr. Captain Sheshasai and Dr. G. Baby Shalini as Secretary. From Eluru OBGY Society, we have got President Dr. Nirmala Devi Bachoti Madam and Secretary Dr. Lakshmi Shri M. From Guntur OBGY Society, we've got a very senior gynecologist, Dr. Bira Venkateshwara as President and Dr. Uma Shankar SN as Secretary. I had the honor of meeting both of them in Angol recently. From Kadapa OBGY Society, we've got President Dr. Usha Rani Baireddy and Secretary Dr. Pramoda Reddy. From Kakinada OBGY Society, we've got President Dr. Satyavati Ma'am is there with us in the program and Dr. Madhvi as Secretary. From Kurnool OBGY Society, we've got President Dr. Venkatraman and Secretary Dr. Radha Lakshmi. Radha Lakshmi has joined us from New York. Nandyal OBGY Society, we've got President Dr. Nagamani Chituluru Madam and Secretary Dr. Vasudha Rani. From Nellore OBGY Society, we've got President Dr. Supraja K. Madam and Secretary Dr. K. Lalita. From Angol OBGY Society, we've got Dr. Nalluri Aruna Rao Madam as President and Anna Mula Devi Madam as Secretary, who have done a wonderful job by organizing a brilliant APCOG recently on the 11th and 12th of July at Angol. Next, we have got Prodetur OBGY Society. This is a new society which has been added from Andhra Pradesh to Foxy. Headed by President Dr. Padmalata Madam and very dynamic Secretary Dr. Pratima Desai. Rajamandri OBGY Society, which is now going to host a conference of Foxy, I think it's a Yuva conference they'll be hosting, headed by President Dr. Padma Sajja Madam and Secretary Dr. Lalita. And Sri Kakulam OBGY Society, headed by President Dr. D. Parvati. The past President Dr. Revati Pandula has also been invited as a dignitary. Secretary is Dr. Prashanti. And Tirupati OBGY Society, headed by President Dr. Partha Sarthi Reddy sir, is there with us, and Secretary Dr. Uma Devi Rala ma'am. Vijayawada OBGY Society, headed by President Dr. Himbindu Palutla and Secretary Dr. Vijaya Malipedi. Vishakhapatnam OBGY Society, headed by President Dr. Sandhya Devi Madam, Secretary Dr. Sunanda Rani. Next, we come to the 13 societies of Telangana. From Bhadradri OBGY Society, also Bhadrachalam, it is called, I think, President Dr. V. Jayabharti ma'am, who is also our moderator for today, and Secretary Dr. Padmavati ma'am, who has joined the program. Hyderabad OBGY Society, popularly known as OGSH, headed by President Dr. Usha Rani, Secretary Dr. Ananta Lakshmi Paga. Jaktiyal OBGY Society, headed by President Dr. Padmini Kumar and Secretary Dr. Sri Lata Guduri. Karimnagar OBGY Society, headed by President Dr. Kavita S. and Secretary Dr. Purnima Ganji. Khammam OBGY Society, headed by President Dr. Surekha Ravulapalli, past President Dr. Lakshmi Rajeshwari, Secretary Dr. Geeta Lokam, past Secretary Dr. Rehana Begum. We welcome them. From Korutla Medpalli OBGY Society, we've got Dr. Sweetie Anup ma'am as President and Dr. Hepzibah ma'am as Secretary. She was there in Bhopal recently for National IMS Con. We welcome Hepzibah ma'am. And next we have got Mehboobabad OBGY Society, headed by President Dr. Arjun Reddy and Secretary Dr. Indra Sen Reddy. Mehboob Nagar OBGY Society, headed by President Dr. G. Mayuri, past President Dr. Aparna Vatamwar and Secretary Dr. Lakshmi Renuka. Mancherial OBGY Society, headed by President Dr. Nalmas V. Sridevi Madam and Secretary Dr. Alimeni Goretyala. Nalgonda OBGY Society, headed by President Dr. Vasanta Kumari, past President Dr. Manjula and Secretary Dr. Rajeshwari Praveen. We welcome them. Nizamabad OBGY Society, headed by President Dr. Padmini Reddy and Secretary Dr. Kiran T. Siddipet OBGY Society, headed by Dr. Ashok Kumar Gururi sir and Secretary Dr. Rajni Gada. Warangal OBGY Society headed by Dr. B. Sandhya Rani Madam and Secretary Dr. K. Anusha Reddy. So next I thank my co-convener Dr. Randhir Singh, and I'm your host for today. My coordinators have been contacting you, messaging you. These are two very sweet young gynecologists, Dr. Purva Bhatkur. She's Associate Professor at GMC Bhopal, my alma mater, and Dr. Virur Srivastava is a renowned fertility specialist in Bhopal. So that brings us to the academic session, and I think it's 5:30 exactly. And Sonal ma'am, I will call her. Purva, you can start the session one. Thank you so much, all of you. Thank you.
So moving to our first academic session, that is on scanning the spectrum of gynecological pathologies on ultrasound. We invite Chairperson Dr. Manjula Raupula Madam. Madam is presently past President of Nalgonda OBGY Society. We welcome you, ma'am. We have with us Dr. Nagmani Chituluru Madam. Madam is presently President of Nadial OBGY Society. We welcome you, ma'am. We have with us Dr. Naluri Aruna Rao Madam. Madam is presently President of Ongole OBGY Society. We welcome you, ma'am. We have with us Dr. Padma Sajja Madam. Madam is presently President of Rajmundri OBGY Society. We welcome you, ma'am. We have with us Dr. Partha Sarthi Sir, Reddy Sir. Sir is presently President of Tirupati OBGY Society. We welcome you, sir. We have with us Dr. Sari Lena Kavitha Madam. Madam is presently President of Karimnagar OBGY Society. We welcome you, ma'am. We have with us Dr. Savitri S. Madam. Madam is retired professor and head of the department, KMC Kurnool. Welcome you, ma'am. We have with us Dr. Shama Sultana Madam. Madam is presently consultant gynecologist at Guntur. We have with us Dr. Supraja K. Madam. Madam is presently consultant at Nellore. We welcome you, ma'am. Now I hand over the session to our chairperson to introduce our speaker, none other than Dr. Sonal Panchal, Madam.
Hello.
Hello.
Vasudha ma'am, could you do the honors? Vasudha ma'am, are you there?
Savitri ma'am is also there.
Yeah, Savitri ma'am, could you do the honors? Vasudha ma'am is there.
Yeah, I'm here, ma'am.
Yeah.
Please introduce the speaker, madam.
Yeah. Good evening, everybody. It's my privilege to introduce ma'am. I had the opportunity of meeting ma'am in Prodhutur recently. Madam is consultant at Dr. Nagori's Institute for Infertility and IVF Center at Ahmedabad, India. She has done her PhD in ultrasound in gynecology and infertility. And she's done her master's in ultrasound in OB-GYN at Ian Donald Inter-University School of Medical Ultrasound. And she's professor at Dubrovnik International University, National Academic Director of Ian Donald School, India, Director, Center of Excellence, Ian Donald Inter-University School of Medical Ultrasound, Ahmedabad. Madam is also National Advisory Board member for International Journal of Infertility and Fetal Medicine, JP publication. She's also a reviewer for Journal of Human Reproductive Sciences, published 45 papers in national and international journals, delivered more than 800 lectures, contributed in and authored several books, more than 120 chapters, and a keen interest in infertility, gynec ultrasound, and 3D, 4D ultrasounds. Madam, we welcome you and we are really waiting for your talk. Thank you.
The madam is just logging in. So whoever is, please communicate all our audience and to all your postgraduates. Whoever misses this lecture or this session can easily see it on YouTube. It will be uploaded on YouTube in 48 hours. And it is free for anybody to view. This channel link will be shared in the group. And you can pass it on to your students, postgraduates, colleagues, anyone. Good evening, Sonal ma'am. Namaste, ma'am. Ma'am, you have been introduced. Ma'am, please unmute, ma'am. Yeah.
You want me tell me when you want me to start, okay?
Ma'am, you can start because
Oh, right now, right
yes.
away. You
These
said
are
5:40.
yes, ma'am, but I finished early.
Okay, fine.
I went
Ajay.
I went to with the top speed, I wanted to have more time for you.
Okay, thank you very much. Thank you very much. Okay, I'll start. So, good evening, everybody. Thank you very much, Monica, for this invitation and this opportunity both. And we are going to discuss today at length scanning in gynecological pathologies. We know that the gynecological pathologies we can divide into uterine, ovarian, tubal, and of course, conditions which are arising out of gynecological causes, which may directly not involve the uterus and ovaries or the tubes, but may still involve the structures in the pelvis and will lead to diseases like endometriosis and so on. We may also discuss a little bit of ectopic, it is the diagnosis of it, when we discuss the tubal pathologies. Talking about, when we want to therefore diagnose these pathologies, it is very, very important that we do a systematic scan, a systematic transvaginal scan, of course. First, an abdominal scan, which would allow us to get a proper orientation and not to miss any associated abnormalities. But after that, a detailed and a systematic transvaginal scan is what is required. One should start observing the screen from the time the probe is right on the enteroitis, where you can see the symphysis pubis, you're seeing the urethra, you're seeing the bladder here, and then you're seeing the vagina, the anterior wall, the posterior wall, the vaginal canal, and you're seeing the rectum and the back. So that's the bowel, part of the bowel. As you gently slide the probe in, and remember the probe is introduced in a way so that the marker on the probe always faces the anterior aspect of the patient, and it is this marker which always correlates with this logo. So if you want to understand the orientation of this image, this is the foot end, this is the firing surface of the probe. We call it a footprint. And that is in the vagina. So that is the caudal end, and this far end is the cephalic end of the patient. And then we are seeing here the anterior aspect of the patient, and that is the posterior aspect of the patient, because it is this logo which correlates with the marker which is going to face the anterior aspect of the patient. So having understood that orientation, we are going to, we further introduce the probe, the marker remaining anteriorly, just sliding the probe in, not screwing in. And as you do that, you are going to cross the entire vagina and you will touch the cervix. If the uterus is seen in the midline, fine. If it is not seen in the midline, you are going to span the probe as it is done here. And if you span the probe and you come, you can see the mid-sagittal plane of the uterus. It means that the uterus is deviated onto one side. And if the uterus is deviated, you must evaluate what is the cause of deviation, which may be Mullerian abnormalities, or it may be an extrauterine lesion in the pelvis, which is pushing or pulling the uterus onto one side. And if you are not seeing the entire mid-sagittal plane even on spanning, which means that you're either seeing the endometrial cavity or you are seeing the cervix, not the entire mid-sagittal plane, it means it might be a twisted uterus. In those cases, you're looking more for uterine involvement, asymmetrical involvement of the uterus for any pathologies like localized adenomyosis or large fibroids and so on, or adhesions. Once you are in the mid-sagittal plane, consider this as your central plane, and you are going to span the probe from one side to the other side to evaluate the entire uterus And when you say you are going to evaluate the entire uterus, you are going to see the serosal contour, which should be smooth and pear-shaped. You are going to check both the myometrial walls. They should be homogeneous and equal in thickness. And you are going to also confirm that the junctional zone, which is an hypoechoic area surrounding the endometrium, is intact and equal in thickness on both the sides. You would see that the endometrium is pear-shaped, and you would see that the central line is thin. Having done this, as you span the probe from one side to the other side, before you move away from the longitudinal section, you can measure the uterine length, the anatomical uterocervical length, which is measured from the serosal fundus till the external os. And remember, as a rule, it is always to be measured not as a straight line, but following the entire endometrial cavity and its curvature. And the same is done afterwards to measure the endometrial trace, or we can call it a physiological uterocervical length. Having done this, now we can bring the fundus right in the center. So this is spanning the probe across to look for any abnormalities. You may go further laterally, and as you go further laterally, you may see anechoic serpentinous tubular structures at the level of the internal os, and this is the uterine artery. Now, when you want to measure the flow in the uterine artery, you can put in the color, but it is important that you further move your probe laterally. As you move your probe laterally, you would see vessels, but you are not seeing the uterus in the background, which means you are outside the uterus. You need to move a little more medially from this before you measure the flows, because when you measure the flow in the uterine artery, when the uterus is not in the background, it means that you're measuring the flow outside the uterine. You want to measure the flow in the uterine only after you enter the uterus and before it divides. You bring now the fundus in the center, and then you can zoom the image, and it is in that section that you would want to measure the AP diameter and the endometrial thickness. With the fundus in the center, when I rotate the probe 90 degrees, I would see the transverse section of the uterus. Description appears to be very long. It doesn't even take more than exactly 1 minute to finish the detailed assessment of the uterus. Remember, both the endometrial thickness and the AP thickness are measured perpendicular to the central line of the endometrium, and the transverse diameter is measured as the longest diameter side to side, parallel to the transverse axis of the endometrium. You would then span the probe to see the entire uterus in the transverse section up and down, and so that means anteroposterior, and then you would span the probe laterally to locate the ovaries. To locate the ovaries, you are going to trace the soft tissue adnenaxal band from the fundus to the ovary, which extends from the fundus to the ovary. This consists of naturally the tube, the vessels, and the ligaments. And this is very essential because most of the times a normally placed ovary can be traced like this. And when you trace the soft tissue adnenaxal band, you're also looking at its thickness, and that would help you find out if there is any inflammation of the tube. We will look at that in detail when we discuss about the tubal pathologies. You have located the ovary, you are going to rotate the probe, find out the longest axis of the ovary, freeze it on one frame of the dual frame, and then you are going to measure the longest diameter and the longest diameter perpendicular to that long diameter. Rotate the probe 90 degrees anti-clockwise and get to the transverse section of the ovary on which you are going to measure longest diameter parallel to the x-axis. Having done that, you would check for the mobility of the ovaries by in and out movement of the probe and observe the Powell loops moving around. You would do the same for the second ovary. You would go to the pouch of Douglas. So you come back to the center, you're seeing the uterus, you'll angulate your probe posteriorly and you'll see the pouch of Douglas. And that is how you would almost complete your basic examination. If you are wanting to measure the flow in the ovarian stroma, you're going to locate the ovary and you would see the flows, the vessels right in the center of the ovary, not close to the follicles and away from the hilar vessels is what you're going to do to measure the stromal flows. You're looking at the opposite ovary, and that almost finishes your scan for the pathologists, for the major pathologists. So that is your systematic way of doing the scan. Now, starting with the abnormalities, of course, when we talk about the uterine abnormalities, we would want to divide them into the Mullerian abnormalities or the congenital abnormalities and the acquired abnormalities. But the congenital abnormalities, the Mullerian abnormalities are going to be discussed later on by Dr. Jayabharati in detail, so I'm not touching it at all. I'm directly moving towards the acquired pathologies of the uterus. If you talk about the acquired pathologies of the uterus, that can be chiefly divided into the inflammatory pathologies and the neoplastic pathologies. If we say inflammatory, it is usually the endometrium, which is more affected with the inflammation, though along with that, myometrial inflammation is known, but it is not always documented on ultrasound. Endometrial inflammation, if we talk about, it can be acute endometritis, it can be chronic endometritis. And you might have observed most of the times that you would barely in your reports read about acute endometritis. Why? Because we probably have not paid attention to it. And why is that so? Is because acute endometritis can be diagnosed only in the early proliferative phase. Acute inflammation anywhere in the body leads to two things. One is edema and second is hyperemia. That means that with the endometrial inflammation, the endometrium is going to get thickened and it is going to get vascular. And these are the normal changes seen in all the other phases of the cycle except for the early proliferative phase. Therefore, it becomes very difficult for us to diagnose that the endometrium is pathologically thickened and it is pathologically hypovascular. And therefore, it is very difficult to identify. It is very, very difficult to diagnose acute endometritis in the phase in the proliferative and in the secretory phases. So if on the early proliferative phase you find that the endometrium is thickened, it appears sort of homogeneous in echogenicity, not multilayered. It shows irregular junctional zone, and if you put on a Doppler, it shows extremely increased vascularity. These are the findings which tell us, yes, this is an acutely inflamed endometrium. And this is very important to diagnose because whenever the whenever the inflammation is diagnosed early during the cycle, early during the pathology, that is when treatment with a long course of antibiotics completely resolves it. And that is a very, very useful diagnosis to be made early, and it is a very useful way of treating these patients. Coming to chronic endometritis, of course, when I say chronic endometritis, the first thing that comes to our mind is tuberculosis. But remember, tuberculosis is not the only pathology. Chlamydia is equally common, and unfortunately, tuberculosis and chlamydia have a very similar presentation. What are the findings that we find with chronic inflammation? And I'm telling you, I'm not specifically talking of tuberculosis alone. I will tell you what are the signs which are more specific for tuberculosis. For any pathogen leading to chronic endometritis would show you a persistently thin endometrium even during the pre-ovulatory and the secretory phases. The junctional zone is thickened and irregular. You may see very tiny hyperechoic or calcified flecks in the endometrium in the junctional zone. You may also see them in the myometrium. You may see fluid in the endometrial cavity in the mid-proliferative phase, day 6 to day 10 in a normal length cycle. which is usually not the phase when you would see the fluid. Moreover, you would see that the inner margin of the endometrium appears hyperechoic, and that is because of fibrosis. Apart from that, because of this chronic inflammation, you would see, and especially when it is because of tuberculosis, which leads to endarteritis, you would see almost absence of vessels in the subendometrium. You may see tiny hyperechoic flecks in the junctional zone, and micropolyposis are the findings that you would see on your 2D ultrasound. But when you switch on your 3Ds, or you put in saline, one of the two interventions, that's when if you put fluid inside, you may see irregular inner margin of the endometrium, which may be seen on your 2D scan without putting saline as irregularity of the central line of the endometrium, which is a very subtle but a very important sign to be diagnosed and documented. Apart from that, on the 3D, you may see that there may be scarring in the endometrial cavity. You may see that there is a contracture of the endometrial cavity, which appears like a so-called T-shaped uterus, but it is not truly a T-shaped uterus. You would also see a vertical orientation of the interstitial part of the tube. Now, if you look at any normal uterine cavity, we know that the interstitial part of the tube from the triangular endometrial cavity runs laterally. So it's chiefly laterally, mildly superiorly. But here it actually stands up, which is called a vertical orientation of the interstitial part of the tube. And this is one of the most specific signs of tuberculosis. It is not 100% specific, but it is one of the most specific signs of tuberculosis. So that is why whenever you suspect chronic endometritis, a 3D ultrasound is very, very important. So this is what I was telling you. You would see irregularity of the central line of the endometrium, and this is a very subtle but a very important sign to tell you there is chronic endometritis. And it is in these cases that I would want to draw your attention, especially because you can see the endometrial thickness is not bad, but in spite of that, the central line is very, very irregular, which tells you, yes, this is an inflamed endometrium. And it has been documented in the literature also that patients with chronic endometritis not necessarily always will have a thin endometrium. They can have an endometrium which grows to up to 6.5, 7 millimeters. But if the central line is not regular, if the central line shows hyperechoic areas, if the central line shows discontinuity, and if you put on a color Doppler and you see that instead of the spiral vessels alone, you may also see some random vessels running parallel to the long axis of the endometrium. These are the signs which tell you, yes, this is probably a chronic endometritis, though the endometrium appears multi-layered. So that is about the chronic endometritis. But whenever there is a chronic endometritis, we know that synecdoche are very, very common. And synecdoche are not easy to diagnose in an early proliferative phase. Why? Because synecdoche would lead to, depending on their thickness and their numbers, they would, or their population, they would lead to inability of the endometrium to grow. But it does sometimes happen that in spite of synecdoche, you may see some minimal growth of the endometrium. It may grow to 5.56 and may also appear multilayered. But again, as I told you for the chronic endometritis, the same fact also stands here true, and that is 1, irregularity of the central line, 2, hyperechoic flex in the endometrium, 3, there may be broken central line. You would see naturally irregularity of the junctional zone. Moreover, you will see sometimes tiny fluid loculi, which we will see in the next slide, tiny fluid loculi in the endometrium, and these are all the signs which suggest there is a possibility of synecdoche. But the confirmation of the synecdoche is only done by putting saline in it, because when you put saline in it, the endometrial cavity, which is devoid of the synecdoche, will open up, will widen up. Whereas if there are synecdoche, in spite of putting fluid inside, the two walls of the endometrium are attached together, so you will not see any filling of the fluid. So here in this case, if you see, it is the upper half of the endometrium which is completely frozen because of synecdoche, whereas in the lower half you are seeing some fluid locules, but you are also seeing those hyperechoic flecks and strands which tell you there are synecdoche even in the lower part. The fluid loculi that I told you about in synecdoche can be seen even in absence of excess fluid put from outside. That means even when you don't do a saline infusion, even if then you are seeing a persistently thin endometrium and you are seeing fluid loculi in the endometrium, this tells you there are synecdoche. So I come back, persistently thin endometrium, fluid loculi, irregularity of the central line, hyperechoic flex, fluid fill loculi in the endometrium. Yes, and these are all the signs which tell you there may be synecdoche. And if you put in the fluid, you can actually see the synecdoche. If you do put in fluid, saline infusion, and do a 3D, it's even better. And these are all the pictures of synecdoche in the endometrium with the 3D and with the saline infusion. Moving further to the next endometrial pathology, and that is the polyp. And that is sort of neoplastic, of course. This is an extra growth that occurs from the endometrium. It is focal. It may appear round or oval. It is usually seen as echogenic lesion, round or oval in the in between the three lines or the multi-layered endometrium. They may vary in size. They may be single or multiple. But if you see it as a single and a round or oval, you're pretty sure it's going to be a polyp. But when it is too big and it fills up the entire endometrial cavity, it may be difficult to differentiate it from hyperplasia. Or if it is very tiny and it is very subtle, it is in these cases that only the irregularity of the central line of the endometrium, which appears irregular, allows you to see there is some subtle lesion underneath this line, which probably is the tiny polyp. And you may put on a Doppler to see the feeder vessel. You know, the feeder vessel is a single feeder vessel is what is considered a diagnostic Doppler criteria for the polyp. If you would remember, when I was talking about synecdoche, I didn't even mention Doppler, because synecdoche, as we know, is a result of fibrosis. Usually synecdoche and even the endometrium, therefore, are severely hypovascular or avascular. That is why I did not mention anything about Dopplers there. But yes, when you want to diagnose a polyp, you usually put on a Doppler, and if you see a single feeder vessel, you know it is a polyp. But it is very important to understand here that when the polyps are so subtle and tiny, because the blood vessels will have feeder vessels will have a very, very low velocity, the vessels may not be easily diagnosed. And it is in these cases, in both these cases, in very, very tiny polyps and even in large polyps, which fill up the entire endometrial cavity, it is in these cases putting in saline and doing a saline infusion sonohysterography can show you the margins very well. Apart from this the echogenic solid lesion, there is one very important thing that you can see here. If you're looking at the margins of the polyp, here at one area, you are seeing a bright edge of the polyp, and this is nothing but the polyp surface completely touching the inner wall of the endometrium. And that is whenever there are two smooth surfaces, they touch each other on the in the body, that's when you would see that bright edge, and bright edge is therefore considered as one of the signs of polyp. Polyps usually are ecogenic and they are homogeneous in ecogenicity, but sometimes they may appear heterogeneous. And when they appear heterogeneous, they may be senile polyps, there may be atypia, or they may be adenomyomatous in origin. So let's go back and talk about, yes, so if the polyps are large and fill up the entire endometrial cavity, you may be often confused it is a hyperplasia or a polyp, but it must also be kept in mind this might also be multiple polyps which are touching each other. It is therefore that you may put on a Doppler, and if you put on a Doppler, if it was multiple polyps, you would see individual vessel entering in. If it was a hyperplasia, you're going to see symmetrically distributed blood vessels. And if it is a single polyp, you're going to see a single feeder vessel. But 3D also may be a helpful modality to differentiate between polyps and hyperplasias. In hyperplasias, you are going to see a long segment of thickening. Not only that, it is 3D, which will also help you find out which wall does have the pedicle. That means which wall does the polyp arise from. It's arising from one of the side walls, it's arising from the fundus, or whatever. And you would also be able to find out whether it is a sessile polyp or it is a pedunculated polyp. That may help you in the management. But as I told you, the moment you put in saline, that's when you are going, the polyp is actually going to pop inside the endometrial cavity as if you are looking at Hello? Hello?
Hello. Yes, ma'am.
Yeah, there was probably somebody speaking. I thought they were telling me. Okay.
They're
There's
muted.
nothing, right? Fine.
Sorry.
So that means when you put in saline, that's when the polyp is going to actually pop out, and it gives you some pictures exactly similar to your hysteroscopies. So this you can call a virtual hysteroscopy. Even if there are multiple polyps, you can compare the hysteroscopic to the saline infusion, so no hysterography pictures. So the polyp, for the diagnosis, you can do a 2D, you add Doppler to it, you add saline infusion, and you add 3D ultrasound. And this can easily differentiate between your hyperplasias and the polyps. Now, coming further to hyperplasias, therefore, if you find a thickened endometrium, that's when you think about hyperplasias. But there's one point which is very, very important. Looking at our conventional literature, it tells us if there's an endometrial thickness which is more than 5 millimeters in a postmenopausal patient, more than 15 millimeters in a premenopausal patient, you start thinking about hyperplasia, but it says you should start thinking about hyperplasia. It doesn't say it is a hyperplasia, because it's very important to understand that in a stimulated cycles, you may often find endometrium which are thicker than 15 millimeters in both the preovulatory as well as in the mid-luteal phases. But if the morphology is normal, it is not a hyperplasia. On the other hand, you would also see endometria which are barely 10 millimeters even in the premenopausal age, but they show a typical morphology which is of hyperplasia, which is not a normal multilayered endometrium, which is not an endometrium which fits into the normal secretory phase also, and these are hyperplastic. That means that it is not the thickness which tells you about the hyperplasia. It is actually the morphology which is more important. And what is the morphological criteria of a hyperplasia? An endometrium which appears hyperechoic, which shows multiple tiny anechoic areas inside, and the junctional zone is most of the times, if there's no associated pathology, is going to be normal. This is what can be hyperplasia. And then there are two different morphological variants also. There may be an endometrium which is thickened, which has multiple anechoic areas, which are variable in size. Some of them are larger, some of them are smaller, whereas there would be a more homogeneously hyperechoic endometrium with multiple tiny anechoic areas only. And this one, where you're seeing multiple tiny anechoic areas, more homogeneous, is a stromal predominance in the hyperplasia, and this is a glandular predominance in the in the hyperplasia. So, and as I told you, for both, there is going to be a regular distribution, a symmetrical distribution of the blood vessels, though it has been found that the glandular or the cystic hyperplasia is less vascular as compared to the stromal predominance. Coming to the calcification of the endometrium, whenever you find calcification in the endometrium or in the subendometrium, that is when it is very, very important that you would always do a 3D for this. Why? It is important to find out as to how much thickness of the endometrium is truly involved in the calcification, because if it involves the entire thickness or it is more than half of it, that means that there is going to be hardly any potential for the conception. But if it is in the subendometrium, there's still a potential for a conception for that patient. Calcification, though, is confirmed only by the posterior shadowing. So there's a difference between the hyperechogenicity, which may be because of fibrosis, and there's and the calcification where there's a hyperechogenicity with posterior shadowing. So whenever you see calcification, you're going to do a 3D, and then it is essential that you would rotate that image. And when you do that, you can very beautifully see here as to how much of the thickness. See, if we are rotating it, we are seeing almost the entire thickness of the endometrium being involved by the calcification here. But if it was in the subendometrium, you may see the endometrium separately and the calcification separately. So for all endometrial calcifications, 3D is essential. So that was practically about most of the commonest seen endometrial lesions. Let's move to adenomyosis. Let's move to myometrial lesions. And in the myometrial lesions, we know the commonest are going to be adenomyosis and fibroids. And we will also discuss a very fashionable diagnosis these days, which is enhanced myometrial vascularity. Adenomyosis, we all know about the definition. It is an ectopic placement, position as well as growth, and it's an active endometrium, therefore, of the endometrium inside the myometrium. And this is what is called adenomyosis. Because of the deposition of the endometrial tissue, because it has a different echogenicity, it has a different morphology as compared to the myometrium, you may see multiple hyperechoic dots, some hyperechoic lines, sometimes larger hyperechoic islands in the myometrium, which are because of endometrial deposits. But when there is bleeding inside, when there's a blood collection, you would also see tiny hypoechoic areas inside those hyperechoic areas, and this is what we call myometrial cysts. So you have hyperechoic dots, lines, hyperechoic islands, as well as myometrial cysts, and these are all because of deposition of the endometrial tissue into the myometrium, and therefore they are called direct signs of adenomyosis. But it is true that before we see this, we are going to see that the endometrium is, we are going to see that the uterus is enlarged. Not only enlarged, it has lost its pear shaped and it has become more globular. And that is where we write bulky uterus. It's very important here to understand that adenomyosis, there's no term actually like bulky uterus. You have to say the uterus is enlarged, but that is not enough description for the adenomyosis, because the adenomyosis leads to increase in the bulk of the myometrium. It actually forces the uterus to lose its pear-shaped pattern. It becomes more globular. And that is what, and therefore adenomyotic uterus are described as globular enlarged uterus with heterogeneous myometrium, which is because of hyperechoic dots, lines, and because of myometrial cysts, but it is this endometrium which progresses to the myometrium through and during this growth it crosses through the junctional zone, so it leads to marked irregularity of the junctional zone. Sometimes it leads to obliteration of the junctional zone, and sometimes it leads to complete inaccessibility of the junctional zone. And these are also very important signs, though not direct. These are called indirect signs of adenomyosis. So indirect signs of adenomyosis would be enlargement of the uterus. You have a junctional zone abnormality, which may be irregularity, obliteration, or inaccessibility. Because of asymmetrical involvement of the uterus in adenomyosis or because of adhesions due to associated endometriosis, there's a possibility that the uterus loses its normal curvature. It takes a reverse curvature beyond the upper beyond the cephalic half of the uterine body, and this is what is described as a question mark or a year sign of the endometrium of the uterus. And this is also one of the very important signs of indirect signs of adenomyosis. It is because of those multiple anechoic areas and the hyperechoic areas that you would see there are some areas of acoustic enhancement and there are some areas of acoustic shadowing. What is enhancement? Behind a lesion, if you are seeing a brighter ultrasound shadow, tells you it is enhancement. If you're seeing a black or an anechoic shadow, it tells you it is attenuation. So you would see alternate shadows of acoustic enhancement and acoustic shadowing, and this leads to typical fan-shaped shadows, and as described by Musa. And this is better seen always on a live clip as compared to the still picture. And this is what is called, so it is alternate hypoechoic vertical strands posterior to the lesion, and this is what is called fan shadows, is another and indirect sign of adenomyosis. If you put on a Doppler surrounding the myometrial cyst, you are likely to see vascularity, and this is a very important sign, especially when you want to differentiate adenomyosis from tuberculosis. When we described tuberculous endometritis, I forgot to tell you one sign, and that was, apart from the rest of the things that we saw, the vertical orientation of the tube, the thin endometrium, the micropolyposis, calcifications, and hyperechogenicities, fluid in the endometrial cavity, it is important to know that in some areas you may see cystic lesions in the myometrium, which are called myometrial cysts. It is both in tuberculosis as well as endometritis that you would see irregularity of the junctional zone, and therefore, and both would lead to the inability of the endometrium to grow and the thin endometrium. But if you put on a Doppler, it is in adenomyosis that you would see peripheral vascularity surrounding the cystic lesions. This will not be seen in tuberculosis, and this is an important differentiating point between an adenomyosis and tuberculosis. Let us then go further, and if we have started doing Doppler, what are the other Doppler findings for the adenomyosis apart from the vascularity surrounding the myometrial cyst? The vascular arrangement in the adenomyotic tissue is very, very chaotic. Instead of the vessels, the spiral vessels, which are parallel to each other and the perpendicular to the endometrium, you would see multiple vessels which are chaotically traveling everywhere in all directions. And this is this is what is seen in adenomyosis. Not only that, adenomyosis usually, because it's an invasive disease, the lesions do not have sharp margins, and therefore the vessels are also not demarcated by the margins of the lesion. They actually run through and through. They disregard the margins of the lesion, and therefore these vessels are called translesional vascularity around according to the Musa guidelines. And moreover, it has been observed that the adenomyotic vessels usually have a larger diameter than the normal spiral vessels. So if I put together the Doppler findings of adenomyosis, you would have vascularity surrounding the myometrial cyst, you would have chaotic arrangement, you would have translational vascularity, and you would have vessels which are larger in diameter than the normal spiral vessels. And I'm sure you remember the direct and the indirect signs. The direct signs, hyperechoic dots, lines, islands, and myometrial cysts, and indirect signs, the irregularity of or abnormality of the junctional zone, the globular shape of the uterus. You would see the ear sign or the question mark sign. And you may also sometimes, if it's a focal lesion, you may see irregularity or abnormal shape of the endometrium too. So those are the signs of adenomyosis. But if I said so much about vascularity, remember, not all adenomyotic uteri are going to be hypervascular. Some of them will be hypovascular. It is these lesions which will not respond to the medical line of treatment, whereas these ones will respond to the medical line of treatment. The junctional zone, apart from the 2D, can also be assessed on the 3D ultrasound. 3D is considered to be a better modality for the assessment of the junctional zone. You can see it entirely very beautifully and measure the thickness at different areas, and therefore it is considered a modality of choice for assessment of the junctional zone irregularity or the junctional zone obliteration. Because of the better assessment of the junctional zone, 3D is considered as a modality at par with MRI for the diagnosis of adenomyosis. Now, so much about the generalized or the symmetrical adenomyosis, but adenomyosis is not always involving the entire uterus symmetrically. It may involve the uterus asymmetrically. It may not be a diffuse involvement of the uterus. It may be a focal involvement. And those focal lesions may be called focal adenomyosis. Some may be called adenomyoma. And it may also grow inside the endometrium, and it would be a polypoid adenomyosis. So what is the difference between these terms? And they are important to understand. If we say diffuse, it's going to involve more than 50% of the myometrial wall, and they may be symmetrical or asymmetrical. Both the walls may be more than 50% involved, or it may be one of the walls, anterior or posterior, which is more than 50% involved. And this is called a diffuse involvement of adenomyosis. And the findings we have already discussed. Coming to the focal lesion, so that is symmetrical and that is asymmetrical, diffuse involvement of the uterus. Coming to the focal adenomyosis, here you are seeing a lesion which is involving just one part of the myometrium. It is less than 50%, and therefore we call a focal involvement of the endometrium of the myometrium in adenomyosis. But you can see the margins are not very clear, and you cannot actually find out the exact extent of the lesion. So that is why you know that it is focal, but you do not have exact margins of the, you do not have exact size assessment of this lesions. But sometimes, and this is because it's an invasive lesion, but sometimes it happens that it takes a mixed route, you know, it is chiefly invasive, but it has some property wherein it does not invade. Some areas it does not invade into the myometrium. So the parts where it is invading into the myometrium, that those parts of the margins will appear not very sharp and not very clear. With some parts, it would just displace the myometrium. It would not invade inside. And that those parts, because of the displacement of the myometrium, shows a more sharper and a more hyperechoic margin there. And when you see this hyperechoic margin, which is surrounding the focal lesion, you call it an adenomyoma. So when there is no hyperechogenicity, when there's no sharp margins, you call it focal adenomyosis. When you see this margins, which appear very similar to myomas, that means fibroids, that's when you call it an adenomyoma. So those are the focal types of adenomyosis, and then you may also have polypoid adenomyosis. That means adenomyosis in form of polyps. And I did tell you earlier when we were discussing polyps, these polyps are heterogeneous in echogenicity. Not only that, when you put on a Doppler, you would not see just a single vessel, you would see multiple branching of this vessel, which is again a sign of adenomyosis. So instead of a homogeneous polyp, whenever you see that the polyp is heterogeneous, whenever you see there's not just a single vessel, but there is branching inside, this is when it raises a doubt of either adenomyomatous polyp or an atypia. Yes, it is true that you can put a spectral Doppler in the vessels inside the polypoid lesion, and if it shows a residence index of less than 0.4, it does raise a stronger doubt of atypia, but biopsies are very important for diagnosis. Ultrasound is not the diagnostic modality for the same. Sometimes multiple myometrial cysts may join together to form large cystic lesions, and by some people, these lesions are named as a cystic adenomyosis, though there's no as such definite modality like or a definite diagnosis like cystic adenomyosis. But yes, these are multiple cystic lesions which have fused together to form larger cysts in adenomyosis. You can see multiple tiny cysts here also. Moreover, there are some people who have also described adenomyosis as external and internal adenomyosis. We know most of the times the adenomyosis, we have known, I mean, the way we have developed, we have understood the development of adenomyosis, we know it is usually internal. It is the endometrium which grows into the myometrium. Therefore, there is a disturbance in there's an abnormality of the junctional zone. Naturally, the inner myometrium is going to be more involved as compared to the outer, and therefore this is what is called an internal adenomyosis. But in some cases, it has been seen that instead of the endometrium being the causative of the adenomyotic lesion in the uterus, it is actually the bowel endometriotic patch or an ovarian endometriosis, endometrioma. It may get adherent to the uterus, and through the uterine, through the outer uterine wall, through the serosa, the lesion extends into the endometrium, and this is what is called an external adenomyosis. Coming to fibroids, then we know these are well-defined hypoechoic, round, oval, or lobulated lesions, and they are very well-defined. You can see mild hyperechogenicity, usually at the margins, which is because this is not an invasive lesion. It actually displaces the muscle fibers, and therefore the margins are very sharp. You put on a Doppler and you are going to see a ring of color there. And this is because, and these vessels that you see which form the ring of the color, they are not actually fibroid vessels, they are actually myometrial vessels which are displacing, and therefore they lead to a very clear rounded contour of the vascular ring. So those are typically fibroids, and apart from these findings, a very typical finding that you would see in a fibroid is that because of the, yes, so just like your adenomyosis, you are going to see shadows in the fibroid also. So we were all for a long time thinking that fan shadows, which were earlier described as Venetian blind pattern or rain in forest pattern, was a very typical finding of of an adenomyosis. But remember, it is not a finding of adenomyosis. It is a very common finding for any myometrial lesions. Though in adenomyosis they are more finer, with the fibroids they're more coarser, but those fan shadows are seen in fibroids also. But apart from those fan shadows in the fibroids, you are definitely going to see what is called edge shadows. What are edge shadows? Apart from the fan shadows that you see here, on the margin, look at that. You are seeing a very bold anechoic shadow posterior to the fibroid, and that is what is called edge shadow. So edge shadow is typical of a fibroid, and it is only seen in fibroids. It's usually not seen in focal adenomyosis. And that is a very important differentiating point between the two. And we are going to come to the differentiating points. You would think fibroids, why would you confuse it with adenomyosis? Because fibroids are usually more hypoechoic and homogeneous, and the adenomyomas are and the focal adenomyosis are much more heterogeneous. So you're not going to mix up the two. But we know that the fibroids, though they are usually hypoechoic, when they undergo degeneration, that is when, instead of being completely hypoechoic, they may show sometimes cystic areas inside. They may also sometimes show hyperechogenicities. They may also sometimes show calcification in the rim or in the fibroid itself. And when this happens, that is when you actually get confused whether it is a fibroid or it is an adenomyoma. Of course, you may put on a Doppler, and when you put on a Doppler, the confusion doesn't solve. It actually may increase, because when it is a fibroid, otherwise you are going to see only peripheral vascularity, but when it is a degenerated fibroid, along with the peripheral vascularity, you are going to see vascularity inside also. So that internal vascularity confuses you as to whether it is a fibroid or an adenomyoma. But if you look at it a little more closely, the adenomyomas that we saw earlier, and they usually have vessels which are seen inside the lesion. There is they may mostly not have peripheral vascularity, but even if they have a peripheral vascularity, like it is seen in some adenomyomas, the vessels which are inside the internal vascularity in fibroids will be limited by those peripheral vascularity, whereas in adenomyomas, the internal vessels will disregard the peripheral margins and they will run through and through. So that may be an important differentiating point between the adenomyomas and the fibroids. So yes, though we can see the margins, though we would see the edge shadows, though we would see an internal and a peripheral vascularity, we would still get confused between these two lesions. And the clear-cut differentiating points of this, if you're using a 2D ultrasound, in adenomyosis, you're going to see the French shadows throughout the lesion. For the fibroid, you are going to see the French-Shepard shadows, but along with that, you are going to see the edge shadows. Second, for the adenomyoma, even if it is focal, the junctional zone is going to be irregular or obliterated. Whereas for the fibroid, the junctional zone will be displaced, but it is not. It is still irregular. It is not irregular. It is still regular. It is not displaced. It is not obliterated, or it is not irregular. If you put on color, the fibroid will show peripheral vascularity and intralesional vascularity. Intralesional because it is limited by the outer peripheral vessel, whereas adenomyomas will show translesional vascularity. It does not just regard, it does not regard the margins of the lesion at all, just runs through and through. The third important modality of ultrasound, which will help you differentiate the two, is the elastography. Elastography is a technology which measures the firmness of the tissues, and we know that fibroids are much more firm and hard as compared to the adenomyosis, adenomas, even if they are degenerated. And therefore, and this elastography actually shows the entire rainbow spectrum. The hard and the firm tissues, they appear dark blue, and then light blue, and then green, and then yellow, and then red, which is fluid. So adenomyomas will always appear green, yellow, and the fibroids will always appear dark blue. There's one more new modality of ultrasound which will help you differentiate confidently between the adenomyomas and the fibroids, and that is the contrast ultrasound. There are ultrasound contrast available which are absolutely benign. They have no side effects. They can be injected intravascularly. just about 1 to 1.5 ml of intravenous injection is what is required. And as which is injected in a diluted form, and as it is being injected, if you are scanning at the same time, for the fibroids, you are going to see that there is a first filling of the outer margin of the lesion. So the outer margin of the lesion will be outlined, and then entire contrast hyperechogenicity will fill up the endometrium and will fill up that margin. So the area in between the margin. Whereas if it is adenomyosis, it's going to be a sort of a starry night appearance. You could see that the contrast would be full. I mean, it is spreading in all the directions. It leads to a picture like, I mean, very chaotic distribution of the hyperechogenicity. So those are the differentiating points between adenomyomas and the fibroid. And now, therefore, there's a very little chance that you might by mistake operate an adenomyosis and thinking that it is a fibroid. Talking about fibroid, we know it chiefly arises from the myometrium, but it has a tendency to move into all, or to grow into all different directions. It may, from the myometrium itself, it may extend right up to the endometrium, or it may extend right up to the serosa, or if it is large, it may extend from the endometrium to the serosa. And depending on how deep it penetrates, it has been given various names. For example, here there is an endometrium, there's a fibroid which is right inside the endometrium, and we can call it a subendometrial fibroid, or this one as a subserosal fibroid. But this large fibroid you're seeing extending from the endometrium to the serosa, and that is what we usually give hybrid names. We call it 2-5 or 3-5 fibroid. So if we say 2-5, 3-5, I'm sure I'm not included here, but I'm sure that you all know very well about the FIGO classification of fibroids. If I quickly speak about it, if the fibroid is completely, instead of being intramuscular, it is completely protruding inside the endometrial cavity, we call it type O. If more than 50% is inside the endometrial cavity, we call it type 1. If less than 50% is inside the endometrium and more than 50% in the myometrium, we call it type 2. If it is completely intramural but just touching the endometrium, we call it type 3. If it is completely intramural, as we are seeing here, we call it type 4. If it is touching the serosa, as we saw here, it is touching the serosa, but it is less than 50% outside the serosa, we call it type 5. If it is more than 50% outside the serosa, we call it type 6. And if it is completely pedunculated subserosal, we call it type 7. And then if it is in the cervix, broad ligament, we call it type 8, and so on. If there's a lesion which extends from the endometrium to the myometrium, we usually call it, touching both, we call it 3-5. If it is invading into the endometrium and going up to the serosa, we may call it 2-5. Especially when there are fibroids which are completely intramuscular, that is when there is quite a confusion as to which should be the mode of surgery, and therefore it is in these cases, it is very important to always mention the minimum distance of the fibroid from the serosa and the minimum distance of the fibroid from the endometrium, so that it would be a helpful guide for surgery. Similarly, when there are endometrial fibroid type O1 or 2, many times it may happen that though it appears like a type 2 fibroid, there may be a larger intramuscular component also, and therefore it becomes very crucial to decide whether this patient would require a hysteroscopic surgery or a laparoscopic surgery. And therefore, to help this out, we all know about the step W classification, the Lesmar's score, which has been developed by Lasmar et al. And this uses, 1, the size of the lesion, It uses the topographic placement of the fibroid, the lower third, the middle third, or the upper third of the endometrial cavity. How much is the penetration, whether it is type O, type 1, or type 2 fibroid? The extension or the amount of the endometrial tissue involved, or the length involved, whether it is less than one third, it's 1/3 to 2/3, or it's more than 2/3 of the endometrium involved, and whether it is involving the lateral wall or not. The score is being calculated for every fibroid, and that is where you do require a 3D. So for all subendometrial fibroids, 3D is essential. So you calculate the score, and depending on the score, the surgical route can be decided. So when it comes to fibroid, it is of course 2D assessment primarily, then comes Doppler, and then you are going to use 3D. And for the subendometrial fibroids, one may also use a saline infusion that would help you decide whether it is a fibroid, or differentiate between a fibroid and a polyp also. So fibroids, especially as you can see when they're subendometrial, that's when it is a 3D ultrasound, which very beautifully tells you it is type O, it is type 1. Whereas this though appears like intraendometrial, it is actually chiefly displacing the entire endometrial cavity. And this is type 4, and this is again subserosal type 5, and this is again from endometrium, this little 3, and this so assess the relationship of the fibroids with the endometrium, and therefore it makes it is a very essential modality, not only for the diagnosis but also for the surgical planning of these lesions. Especially when there is a type O fibroid. This is when, as I told you, to differentiate between polyp and these fibroids, you may use a saline infusion, you may use a 3D, you may use color again, because the polyp will have a single feeder and the fibroids will have a ring of color. But it's very important to keep one very, very simple thing in mind. Fibroids are usually hypoechoic, and therefore they have a similar echogenicity to that of the intervening areas between the triple line preovulatory endometrium, but they are definitely hypoechoic to the secretory endometrium, which is high, and therefore, if you find that the endometrium appears irregular in shape, if you find that the central line is irregular, you put on a Doppler and you're not able to find out either a vascular ring or a feeder vessel, that's when a repeat scan must be done in the secretory phase, and the fibroids stand out very beautifully in the secretory phase, whereas polyps will almost disappear because they have almost similar echogenicity to that of a secretory endometrium. So those are the differentiating points. Now, if I told you that the exact location of the fibroid is important to plan the surgery, therefore you must be mention every detail of the fibroid in a single paper on a single table, which includes the number, which includes the size of every fibroid. And the remember, size of every fibroid must be measured as 3 longest orthogonal diameters, not just 1 or 2 diameters. You need to mention the echogenicity, which are homogeneous or heterogeneous, and hyper or hypo, which tells you whether it is a degenerated fibroid or it is not degenerated. You must mention about the margins, whether they're round, oval, or lobulated, whether they are well defined or not, whether they are hyperechoic or hypoechoic, so that you know that it's a calcified fibroid or not a calcified fibroid. And if they are not calcified, but they're still hyperechoic margins, it tells you, yes, this is a very well defined fibroid. You need to mention the penetration, which means the type. You need to mention it involves the upper, lower, or the middle or the lower third of the fibroid, right or left lateral wall, so the location. And you must describe the vascular pattern and the vascular score, because that would tell you how easy or how difficult your surgery is going to be, and what what preparations you should do pre-operatively. And this becomes a very, very tedious job, especially when there are multiple fibroids. So there comes in for our help a fibroid mapping software, which actually saves time, which is very precise. And of course, it requires a manual effort, but it gives you a very precise assessment of the fibroids with the endometrium, and therefore can decide as to how easily you can or how difficult your surgeries are going to be. So you want to acquire the volume of the entire uterus, and after that you're just going to outline either the uterus or you're going to outline only the endometrium. When you do this, that is when the software, the AI identifies the entire uterine contour and also the endometrial contour on its own, and it marginates them. At this point, it also calculates the endometrial volume, and therefore this would be an additional help for us to decide whether this endometrial volume is adequate or not for the implantation to occur. And after that, you are going to identify the fibroids manually. You can either just draw a trace, or you can take 2 measurements, or you can take 3 diameters. And as you do that, the 3 diameters are taken in 2 different planes. The 2 diameters are taken in only one of the planes. So you identify the fibroids manually, and once you identify them manually by 2 or 3 diameters, that's when the machine will automatically find out the fibroid. It will not find out, it will identify the fibroid, it will outline it, and you can beautifully see those fibroids in the in relation to the endometrium. So that's how it works. I'm going to slightly, fasten up the things, and you can beautiful. So those are the fibroid mapping software. So that is about the fibroids. Now let's move to the next myometrial pathology, and that is the enhanced myometrial vascularity. This has these days become a very, very popular diagnosis, which we all used to call once upon a time as uterine artery AVM. But I think that was definitely a misnomer, because it's not actually an AVM. AVM is arteriovenous malformations, but here it is actually a very it's not an arteriovenous communication. It is a capillary-like network which is hypervascular. There can be multiple causes of it, but the commonest cause is RPOC, and it usually shows a thickened endometrium, which is heterogeneous in echogenicity, and apart from that heterogeneity, it is this similar with multiple anechoic areas inside, and it is this similar echogenicity which extends into the myometrium. And you put on a color, you are going to see an extremely increased vascularity with blobs of color. And this is what is called an enhanced myometrial vascularity. If it is because of RPOC, usually the endometrial thickness will be more than 10 millimeters, and this very rich vascular network also is going to have a high velocity flow. This rich vascular network in the myometrium, if it has a PSV of more than 20 centimeters per second, with a sample volume on your spectral Doppler of 2 millimeters, this means that it is very active, and these are the lesions where you should never ever plan even a curettage, because it is these vessels which will actually bleed torrentially, because there's a direct extension from the endometrial tissue into the myometrium. There are various lines of treatment, surgical, medical. We will not discuss that at this point of time. Then coming to displaced IUCDs, the placement of the IUCDs can be confirmed by, and if they are displaced, can be confirmed by ultrasound as such. But 3D has brought a true revolution to it. 3D can actually tell you what is the type of the IUCD used. Because it shows its shape exactly. Not only that, it also shows the endometrial cavity and the placement of the IUCD ICDs. So, and if they are displayed in 3D allometry, naturally plan the removal of this ICDs better. Coming to the scar assessment, all scars are not bad. When you see a scar tissue, the scar tissue appears hypoechoic, but you have a hyperechoic fibrotic scar, and this is not called a isthmusal. This is not a weakened scar. Whereas here you are seeing a mild triangular shape, fluid collection. This is comparatively a weaker scar, but here also it is a very tiny fluid collection. It is not even dividing half of the myometrium. The fluid collection does not extend into the endometrium, and these are still fairly controllable, fairly acceptable scars. But when you see that there is quite a large fluid collection in the triangular cavity, you see that it is this fluid collection which is dividing more than half of the myometrium, or maybe sometimes extending right up to the serosa. It has a fluid collection which may also be dribbling into the endometrial cavity. These are what are called isthmusal. So a triangular lesion, a fluid collection which leads to myometrial discontinuity, which is triangular in shape. And these are in the base on the endometrial cavity, these are what are called isthmusals. Not every scar is called an isthmusal. Even if it is not an isthmusal, you can still divide the scars into small when they are less than 2 millimeters and involves less than 50% of the myometrial thickness. They're larger when they are more than 2 millimeters and involve more than 50% of the myometrial thickness. And they're total when you actually would see that there's a direct communication from the endometrium right up to the serosa, sometimes also extending outside the serosa and leading to fistula formation, and these are called total scars. So every scar niche is not an isthmusal. Isthmusal has to be triangular based on the endometrium and should be dividing the myometrium. Otherwise, you may have fluid collections, and these are scar niches, but these are not isthmusals. Therefore, the niche may be triangular, it may be roundish, it may be squarish, it may be, and especially when it is like this, that's when we know it is a very small base. So though they may look like fluid-filled areas in the scar, you may feel the scar is weak, but these are not weak scars, and these are not to be treated as, these three especially are not to be treated as isthmusals. Isthmusal, whenever, as I told you, if it is leaving just less than 3 millimeters of the myometrial wall thickness, if the fluid is persistent, if it flows into the endometrium, leads to symptoms like pain, discharge, and if the patient is expecting fertility, if it leads to fluid in the endometrial cavity persistently, these are the ones which require treatment. You may measure, if I say it leaves less than or involves more than 50% of the myometrium, or if I say that it leaves less than 3 millimeter of endometrium, how do you measure the thicknesses? If you have a triangular defect, you are going to measure the base from one end to the other end. From that margin, you are going to measure the highest point on the niche, and if this, and then you are going to measure from that niche to the serosa. You can take a ratio of the niche height to the remaining myometrial thickness, or there are some people who would measure the ratio of the complete the niche height to the complete myometrial thickness just adjacent to the niche. And if this is more than 50%, that's when you would think about operating these patients. From the uterus, now moving towards the adnexal lesions. We are talking about adnexal lesions. The first thing we need to find out whether it is intra-ovarian or extra-ovarian. For that, we are going to do a sliding organ sign. We are going to see the lesion, we locate the lesion, we are going to locate the ovary, and then we are going to do in and out movement of the probe. If you can move the lesion and the ovary away from each other, or you can slide the two over each other as you are seeing here, or even here, that tells you it is extra-ovarian. But if you're sliding here, the two, you're sliding here also the two. So if you cannot do this, that means it is either intra-ovarian or it is adherent to the ovary. To differentiate between these two, you are going to see another sign. If you see an ovarian tissue surrounding the lesion, which is called a Ream sign, or you're seeing a beak of an ovarian tissue on one side of the lesion, it tells you it is an intra-ovarian. So sliding sign positive, extra-ovarian, beak or Ream sign positive, intra-ovarian, both negative, it is extra-ovarian but adherent to the ovary. So that tells you the origin of the lesion. And now, if you're looking at the lesions which are completely anechoic and intra-ovarian, if you're seeing this in the proliferative phase, the first thing you're going to think about a follicle. And if you think about the follicle, put on a Doppler. And if you're seeing a nice perifollicular flow, even if it is not a mature follicle, it is a follicle for sure when you are seeing a perifollicular flow, because perifollicular flow starts with the dominance of the follicle. If instead you are seeing only scanty flow, there are some vessels here and there, there's not a complete ream of color, or there's not even a ream which is involving more than half of the follicular wall, you would call it and the lesion is larger than 25 millimeters, you would call it a follicular cyst. If instead you are seeing that the shape is irregular and you are seeing barely any vascularity surrounding, you would call it a regressing follicular cyst. If there's no vascularity, it is a simple cyst. And if you're seeing the low level echogenicity inside and hyperechoic walls, this is and with a flow which is high resistance flow surrounding this lesion, it is a luteinized unruptured follicle. You're seeing such a lesion in the secretory phase. Naturally, you would think about the follicular cyst first, but remember there may be residual growing follicles also, because the follicles which were between 11 and 14 millimeter at the time of the surge are the ones which perceive FSH as LH as FSH. They grow for a while, and then with the end of the surge, they cannot get luteinized. They still remain there. So if they are smaller than 24 millimeters, you would still call them residual growing follicles. Whereas if you see they are larger than 25 millimeters, you will call it a follicular cyst. Again, no vascularity, simple cyst. And hyperechoic walls and low level echogenicity is luteinized unruptured follicle. If it was multiple follicular development, it will appear like multiple septi, but it may also require a differentiation from serous cyst adenoma. If you put on a vascular Doppler and you see vascularity in the so-called septa, this would be multiple follicles. And these patients usually have a history of ovulation induction, whereas there's no history of ovulation induction. You see vascularity peripherally, but not in the septal walls. This is benign serous cyst adenoma. If you see a cystic lesion which has thick walls, shaggy walls, hemorrhagic echogenicity inside, which may be fishnet pattern, which may be a honeycomb pattern, which may be fibrin strands, and you put on and you see this lesion for the first time in the secretory phase, you put on a Doppler and you see a beautiful ring of color. This has to be a corpus luteum. If you are seeing scanty flow, it may be an inadequate corpus luteum, but remember it is not an LUF, because LUF will never have hemorrhagic echogenicities inside. If it doesn't show any flow, it may be inadequacy or failure of the corpus luteum. If you're seeing the same lesion in the proliferative phase and there's still flow, it is a residual active corpus luteum. You must check with the endometrium. If the secretory effect is still seen, it is active still. And if it is a thin endometrium that you're seeing, it is a regressing corpus luteum. If you see this structure in the proliferative phase and no flow at all, it is a hemorrhagic cyst. Monica, tell me when I have to stop.
No, ma'am, it's okay. You can finish your talk, ma'am. It's okay.
Okay. So those are, corpus lutea, remember, can have any varied appearances, as you can all see here. These are all corpus lutea. This is a corpus luteum. This is a corpus luteum. So I know that most of us would call this a hemorrhagic cyst, but you can have a similar appearance for the corpus luteum also. And corpus luteum may also appear absolutely isoechoic. It is because there may be a fresh bleed. And it is in this cases only putting a Doppler would show you a ring of color which tells you, yes, this is a corpus luteum. Endometriomas sometimes may have very similar appearances because ultimately even endometrioma has blood and blood products inside. Yes, it is true that the ground glass appearance has been described even by IOTA as a classic appearance of the endometrioma, but this classic appearance is only found in about 60% of endometriomas. In rest of the cases, you may find a vertical fluid level, wherein this is the hyperechoic area or the echogenic area is the whole blood and the debris, and this is the serum. You may also sometimes see multiple tiny areas falling down, which is called a caustic streaming sign. You may see hyperechoic flecks in the walls, and this hyperechoic flecks in the walls are actually found to be most sensitive, most specific sign of endometrioma, even sometimes more sensitive, specific than the ground glass echogenicity. Apart from this 2D signs, what is more diagnostic and what is more important to differentiate these lesions from either a corpus luteum or even a hemorrhagic cyst is tenderness on probe pressure 1, persistence, because the corpus luteum hemorrhagic cyst ultimately are physiological, are going to disappear, at least start decreasing within about 4 to 6 weeks. And third is the associated adhesions. So if you find these 3 signs along with any of the cystic lesions which contains thick fluid, you must think in terms of endometrioma. They have vessels which are called short course vessels, which come and touch the lesion, but they do not run with the wall of the lesion, as you can see in the as you saw in the corpus luteum, and these are called short course vessels. This is because these vessels have very acute branches at very acute curves, acute angles, and therefore not have a very long segment. You cannot see a very long segment in an uneven section. But these are typical appearances of endometrioma. You may have very atypical appearances. They may appear absolutely fluid filled. They may show nodularity of the walls. There may be bright spots in the fluid. There may be you may see a bean sign inside. Sometimes the fluid is very hyperechogenic. Sometimes you see hemorrhagic echogenicities. Sometimes the nodularity may see or show a lot of vascularity. And these are all ultimately endometriomas. As I told you, it is pain on probe pressure. It is adhesions and persistence, which are very, very important differentiating points. But whenever there's an endometrium with pregnancy, it may the endometrium inside the endometrium may also go decidualization. You may see nodular growths, papillarities in the mass, and this may be very vascular. And these are therefore very commonly confused with malignancies. Malignant change, though, in the endometriomas are very, very late, very, very rare. So those are the malignant changes that you're seeing here, and that is the decidualization. Coming further along with that, with endometriomas, you may have endometriosis. For that, you must look the entire posterior compartment, because that is where the endometriomas are very common. But if the symptoms suggest, you must also see the anterior compartment and the parametrium. But if we just, but remember that all the endometriotic lesions have a common similar appearance. They're hypoechoic, irregular walls, peripheral hyperechoic margins, which are often indrawing, and they show a sort of a wavy appearance, penetrating. They may have multiple tiny hyperechoic areas. They're tender on probe pressure, and they involve just one wall of the bowel and not the entire circumference. So here you saw, if I follow this entire clip once again, you are going to observe the bowel, you're going to observe the anterior muscularis of it, you will trace it right up to the fundus of the uterus, which matches with the sigmoid part of the colon. And as you go deeper and deeper, you're still following that line. And as you do that, at one point you saw that this line broadens up. You are seeing here, it is going to broaden up there. You are seeing a large hypoechoic lesion, exactly as I described, hyperechoic dots inside, hyperechoic lines, margins because of myoproliferation. And it may also show adhesions. So that is what is an endometriotic patch in the bowel. You're seeing one patch here, you're seeing one patch here. You cut in the transverse section, and because one wall being involved, it gives a typical signet ring appearance. We will not go into more details of the deep endometriosis. This is a subject by itself, but yes, you must always see for it whenever you are you find endometriomas or there is a definite symptoms. Let's move to, and I'm going to cut off everything about endometriosis, but yes, endometriotic screening is very, very important. Whenever patient has any symptoms, pain, dyspareunia, dysmenorrhea, or the patient has sort of unexplained infertility, remember, deep endometriotic lesions as well as superficial endometriotic lesions are often missed, and these patients are treated as unexplained infertility. You may find mass lesions which are complex, which may have hyperechoic dots or lines. You may have tooth-like projections with posterior shadowing. You may have hyperechoic balls with posterior shadowing. You may have hyperechoic blades with posterior shadowing. You may see hair balls. You're seeing fluid level here, but that hyperechoic echogenic area is anteriorly instead of posteriorly. This is exactly opposite to what we saw in endometriomas. This is because the echogenic area is the fat and it is floating on the fluid. You may sometimes see large hyperechoic ball-like lesions, the posterior walls of which are not identified because these are fat balls, and the fat is a poor transmitter of sound. You're seeing the ovarian margin ream here, which tells you it is intraovarian, and this are called tip of the iceberg sign of dermoids. Dermoids are typically avascular. If you see a simple cystic lesion, anechoic, no solid lesions, no septa, no vascularity outside the ovary, this is a typical paraovarian cyst. It remains round or oval or even on rotation of the probe. But if you see such a lesion, and if you see the fimbrial end of the tube vein very close vicinity of that, think about a fimbrial cyst, which is a very benign condition, doesn't come even in the way of implantation. If similarly, paraovarian cyst also is not important for infertility. If you see a similar lesion, if you see a cystic lesion which is irregular in shape, which is extraovarian, which has septa inside, which changes shape on pressure of the probe, you may see one ovary very close to it. You may see papillary projections, no vascularity. The septa are mobile either on respiration or on pulsation or on movement of the probe. These are typically peritoneal inclusion cyst, and these are again a result of some infection earlier. They are not of any significance if they do not involve the fimbrial end. You may see free fluid with septation, and the free fluid is to be differentiated from the peritoneal inclusion cyst. Peritoneal inclusion cyst is loculated fluid. You will never see floating loops inside. If you're seeing floating bowel loops inside, it is a free fluid. And free fluid with septation, with nodularity, with floating cyst, with the lattice-like pattern would indicate possibility of tuberculosis. Along with that, if you see the ovaries, they show hyperechoic areas, ovarian calcinosis. If they show unexplained decreased vascularity, if they show tiny follicles with ring of color with scanty vascularity in the ovary, the follicle grows but does not develop vascularity, are the signs which tell you it may be tuberculous oophorytis. If you see free fluid and you see floating thickened tube inside, this may be acute salpingitis. Put on Doppler if the vessels run across and have a high vascularity. Along with that, you see that the ovaries appear apparently without follicles, but they're hypoechoic, and a lot of vascularity tells you this is associated acute oophorytis. It is tubal lesions which will result into hydrosalpinges, a rounded lesion which changes shape on rotation of the probe, which may show beak-like extension, which may show incomplete septa, which may show a sausage-like shape. They are all hydrosalpinges. Hydrosalpinges may have narrowings because of hostra, which is called a waist sign on the transverse section. Because of thickened mucosal fold, it may show multiple spikes which appear, which is called cogwheel appearance, and these are all the signs of hydrosalpinges. But depending on the wall thickness and the mucosa thickness and the mucosal fold thickness, you may know that it is of an acute origin, or the smoothness of the muscle wall, smoothness of the mucosa and hyperechogenicity tells you it's a chronic origin. It may get adherent to the ovaries and may lead to tubo-ovarian masses. The only important thing here is we cannot discuss all the malignancies, but remember that any lesion which is irregular in shape, which has heterogeneous echogenicity, which has heterogeneous vascular density, which shows vessels which have irregular or asymmetrical diameter, and the ones which have very low resistance flow are all likely to be malignant. So these are the easiest signs which would tell you when to suspect malignancy. Of course, 3D power Doppler can be very, very useful for the differentiation. I will stop here. I had included ectopics and all, but it is going to be too long, and I know Dr. Jaya is waiting for me to finish. So thank you very much for that patient hearing. Monica told me you have a lot of time, so finish everything and talk slowly. So I've tried to maintain my speed, but
Madam, we would have a few slides about ectopic. Would you like to just speak maybe a 2-3 minutes? Because that will, yes, ma'am, please.
Sure. So the early diagnosis of ectopic which is very important, and it is for that reason that before even you can see the gestational sac, after your cutoff of the Abijah HCG, you must look at the endometrium. If the endometrium shows asymmetrical thickness of the two endometrial lips, as you can see here, this is much thicker than this. This tells you it is an early intrauterine pregnancy. You put on a Doppler and you will see vessels all running towards one single point, which is called a color comet sign, which confirms, yes, it may be an intrauterine pregnancy. But if you're seeing both the walls of the endometrial lips equal in thickness, this is what tells you it cannot be an intrauterine pregnancy. It's not an early intrauterine pregnancy. This is most likely going to be an ectopic pregnancy. The rest of the signs are going to come late. You may see a pseudosac. The pseudosac can be differentiated from a true sac by true sac being eccentric, pseudosac central, double decidual sign in the, so that's a hyperechoic rim in the true sac, no hyperechoic rim here. Irregular shape as a change in the shape or irregularity of the shape with peristalsis in the pseudosac. In the normal sac does not change its shape. And fourth, the peripheral vascularity is always present in a normal sac, not in a pseudosac. So those are the signs in the uterus, but very importantly, it needs to be understood that adnexal lesions, always you are not going to see the typical gestational sac with yolk sac and the heartbeat. This is a very late diagnosis. In a patient with high beta HCG missed period, if you find any adnexal lesion, which is even simply hypoechoic, but it shows peripheral vascularity, it is tender on probe pressure, unless proved otherwise, it is an ectopic. So you must take this as an ectopic and then observe it. If the patient is completely stable, this and the gestational and the ectopic pregnancy grows, the sac which appeared, gestational sac which appeared absolutely, I thought this clips would play, which appeared absolutely isoechoic rounded, then it will show its central hyperechogenicity, bullseye appearance. After that, it will show central anechogenicity. The peripheral vascularity will keep on increasing. You will have the corpus luteum active on the same side if it is an IUI or a fresh transfer IVF cycle. Sorry, not fresh transfer IVF, only IUI cycle. And this would all tell you it is an ectopic pregnancy. So I think I'll stop there. Thank you.
Thank you.
Thank you very much.
Ma'am, you must be tired of speaking.
I'm not tired.
No, but
How are you, Vishal?
It's a marathon.
All well, ma'am, all well.
Yeah, it's a marathon.
So, Madam, thank you so much. Does anybody have any queries for Sonal ma'am? Ma'am, I just have one quick query. Ma'am, you mentioned about the fibroid mapping. And is it a software or we can use that ordinary trace method in E-series machines?
There's an I think it's not an additional software. It is just a function, optional I think function. Fibroid mapping. I think E-series will have it actually. The new E-series will have it.
It's an inbuilt software for the expert series, not for all E-series.
That's
only for expert.
Oh, you are talking about the E10, E8. That doesn't have it. But I think they have now included in the signature also. Signature mein hai?
Not in signature, the latest one.
So
not in signature
is the
20.
latest one, na? Signature is the latest one.
No, after that, one more. Not in signature 20.
I think it is there. Just check. Maybe you are more sure. You must have inquired it, I'm sure.
Madam,
Yes,
we are having very small machines. I have E6. So, ma'am, tell me, if we do the trace method, and then we take the trace to one end of the myometrium, the other end, can we map the fibroid manually that way?
it is better in that case to do simple pencil diagrams that I had showed in the presentation also.
Okay.
That is much more easier and much more simpler.
Yes, ma'am. So I have a radiologist in Bhopal. She is like one of the best over here, and she makes beautiful black marker diagrams, ma'am.
Yes,
Yeah,
yes.
that's what that is
And
required for reporting.
correspond beautifully with the findings.
Yeah, so even I used to do that when I didn't have this software. I used to mark the same fibroids in all the 3 planes. So
Yeah.
yeah,
Yes.
you can beautifully find out that.
Thank you so much, Sonal ma'am. And that was a real marathon and a real treat, a feast for all of us. And
Thank
you have given, total credence to the topic, that is gynecological pathology scanned by ultrasound. I don't think there's anything which is left out except the confusing Mullerian anomalies, which Jaya Bharti ma'am will, now.
She will not leave it a confusion. She is going to be very clear. I have heard her several times, and I know she prepares the things very, very clearly, very beautiful.
It's all because of you.
Ma'am, Sonal ma'am, we are friends from Synergy only.
Yes.
I first met her online and then I became friends with her. And after that, I'm connecting with her again and again.
She's too thorough. She's too thorough. And Jaya, your gift is still lying here. They borrowed us, but they didn't know your seats.
So,
Yes.
so much, Sonal ma'am. Have a nice evening and have a nice
Thank
ma'am.
you, ma'am. Thank you. very
Thank
much.
you.
Jaya,
Thank
ma'am,
you all of you.
we start the panel. I have a pleasure of welcoming amongst us Lakshmi Srikhande ma'am. Madam is a very, very honored guest in Synergy. Synergy is her platform. So we invite her to speak to us and give us her vision about the program, about the topic, as well as what she proposes. She's representing AOFOC. She is going for Foxy presidency. She's past ICOG chair, and we saw some wonderful certificate courses under her chairpersonship. So, Lakshmi ma'am, all yours.
Thank you. Thank you so much, Monica, for making me part of your synergy. And listening to Sonal is always a treat. I mean, I have heard Sonal Panchal many, many times, and she really makes it look so simple. The gynec ultrasound, the follicular tracking, and she talks from basics to advanced. And I'm very keen to listen to Jaya Bharti because I'm sure I will be listening to you for the first time. And I heard so much praise from Monica. Now I will stick to this webinar till the end to listen
thank
to you. And Monica, I would just like to invite all the delegates to the AOFOC conference, which will be in Sydney from 12th to 15th October. The deadline for abstract submission is already over, but we are planning a grand Foxy India night there. And those who wish to join can enjoy Australia, can be a part of that Foxy India night. So I look forward to have many more members to join us in that big group who is going to Sydney, Australia. And wish you all the very best, Monica, not only for this webinar, but also for all your future endeavors. I know you are the much deserving candidate for the infertility committee of Foxy, and I wish to see you there at that post. Thank you once again for having me here.
Thank you so much, ma'am. I'm indebted to you for your love, madam. Thank you so much. So now I think we start the much awaited Dr. Jaya Bharti panel. And I'm sure, Lakshmi ma'am, whatever I have spoken about her, it will be more than that. So
Yes.
she is one shining star who was hidden. And I must give to my friend for giving her to me, and that is Dr. Asha Jain. Dr. Asha Jain is also one brilliant person. I don't know these
Yes.
brilliant people,
Yes.
they attract me too much. So Asha Jain is another person who can speak about any topic under the sun.
Yes.
She introduced me to Dr. Jay Bharti. So, madam, please be with us. And ma'am, you are most welcome to put in your inputs. Dr. Jay Bharti, you have a full panel. So please proceed. Purva, can you please start?
Yes.
All the panelists joined.
Dr. Vishal, yeah, Dr. Vishal, previous slide.
Most of
So moving to a very
Ma'am,
interesting panel.
the panelists are extempore, which will be introduced to you. Yes, ma'am.
So moving to our very interesting panel discussion from confusion to clarity, ultrasound in Mullerian anomalies. I invite moderator Dr. Jaya Bharti Madam. Madam is presently president of Bhadrachela OBGY Society. She is a gold medalist, a true academician, and a very keen sonologist. We welcome you, ma'am. We have with us galaxy of panelists amongst us. We have Dr. Annamula Sridevi, Madam. Madam is presently Secretary of Ongole OBGY Society. We welcome you, ma'am. We have with us Dr. G. Baby Shalini, Madam. Madam is presently Secretary of Chittor OBGY Society. We welcome you, ma'am. We have with us Dr. Kanusha Reddy, Madam. Madam is presently Deputy Director at Fertility 9 Fertility Center. We welcome you, ma'am. We have with us Dr. Kiran T. Madam. Madam is presently Secretary of Nizamabad OBGY Society. We welcome you, ma'am. We have with us Dr. Nishi Venuthana, Madam, presently Secretary of Anantapura OBGY Society. We welcome you, ma'am. We have with us Dr. Padmaja Veera Machanini, Madam. Madam is presently affiliated in Vijayawada, and she has to her credit, she's president, she was past president Vijayawada Menopausal Society. We welcome you, ma'am. We have with us Dr. Purnima G. Madam. Madam is presently fertility specialist and reproductive specialist. We welcome you, ma'am. We have with us Dr. Pramoda Reddy Y. Madam. Madam is presently consultant at Suraksha Super Speciality Hospital, Kadapa. We welcome you, ma'am. We have with us Dr. Prasanthi V. Madam. Madam is a very active member of Ongole OBGY Society. We welcome you, ma'am. We have with us Dr. Sujata Velanki, Madam. Madam is fertility specialist at Vijayawada. We welcome you, ma'am. We have with us Dr. Uma Devi Rala, Madam. Madam is presently Secretary of Tirupati OBGY Society. We welcome you, ma'am. We have with us Dr. Uma Shankar SN, sir. Sir is clinical and fertility head at Vijayawada. We welcome you, sir. We have with us Dr. Vasudha Rani Sabasani, Madam. Madam is presently Secretary of NOGS and Secretary of Vijayawada. We welcome you, ma'am. We have with us Dr. Padmini Kumar Chandupatla, Madam. Madam is presently President of Jagtial OBGY Society. We welcome you, ma'am. We have with us Dr. Shama Sultana, Madam. Madam is presently working as an active gynecologist at Guntur. We welcome you, ma'am. Now I hand over the session to our moderator, Dr. Jaya Bharti. Over to you, ma'am.
Is my screen visible?
Yes, madam.
Do you see my pointer?
Pointer.
Do you see my laser pointer?
Yes, ma'am. Yes.
Okay.
Yes.
So we'll start with the panel discussion. Thank you, Monica, for this wonderful title, Confusion to Clarity, the Mullerian Anomalies. So let us decode CONUTA. CONUTA stands for Congenital Uterine Anomalies. I bring with me the blessings of Lord Rama for all of you from Bhadrachalam. So this is a great day for me because I'm sharing the dais with Dr. Sonal, who taught me and who introduced me to transvaginal sonography. This is me receiving the diploma from Ashim Korea. I did my diploma in Nagari Institute that belongs to Dr. Sonal. This is my first work of 3D ultrasound. Thank you, Monica, for this opportunity. I'll never forget this day. So this is me now with my favorite probe and my favorite subject. I welcome all the panelists. So let us start the prologue. So it is a 14-year-old girl. She comes with severe pain abdomen with syncopal attacks. So Dr. Padmini, can you please describe this image? This is the Foley's bulb in the urinary bladder. Can you please describe this image? Dr. Padmini?
Yeah, I'm here, ma'am. I can see the uterus.
Yes.
And then there is a bulge in the vagina.
Yes, very good.
Which is showing and it is mixed
Collection.
echogenicity, mostly
Collection.
suggestive of
Yeah.
collection.
So
Mostly
this is
blood collection.
Very good. It is a hematocolpus along with
Hematocolpus.
hematometer. What could be the probable diagnosis?
Imperforate hymen.
Yes, very good. It's an imperforate hymen. Shama, this is for you. A 24-year-old. She has a history of preterm labor and now she is having 2 months amenorrhea and precolor test is UPT is positive. Can you please describe this image? Shama?
Yes, ma'am.
Please describe the image if you can. This is the uterus.
Okay. Septum uterus, is it?
Yes, very good. There is a septum seen. And what is this?
Septum uterus.
She's 2 months of amenorrhea. What could be this? It's a gestational.
Ectopic.
No,
Gestational sac in the horn.
Yes, good.
Okay.
So it's a complete septum with a gestation sac in the left heart. Because
Yes, ma'am.
she is having a history of preterm labor, she requires cerclage.
Cerclage.
And Dr. Vasudha, this is for you. A 40-year-old with three normal vaginal deliveries. Now she presents with heavy menstrual bleeding. Please describe the image for me. Dr. Vasudha.
Yeah, ma'am, I am here.
This is an image of uterus, of course. Please describe.
Yeah, it looks like there's a septum right from the fundus right into the cervix.
Yes,
and maybe
very
extending
good.
downwards.
Yes. You can see
so
2
it's a
horns
septum.
and also 2
Horns.
cervices.
Yeah.
So it's a complete septum.
Complete septum.
Why I have put this image is she had 3 normal vaginal deliveries. So her obstetric period was uneventful. And now she presented with a gynae complaint.
Okay.
So this is an interesting case. A second gravida, P1L1 with 16 weeks. And she was referred to me having diagnosed as solid ovarian tumor. I repeated the scan and this was the solid ovarian cyst and it was having a color score of 4. So I decided to have a tentative diagnosis of decidualized endometrioma and I followed her up. And the cyst was of the same size throughout the gestation. And at 34 weeks, I had to do an emergency section for footling and PRO. So Dr. Purnima, can you identify the condition? Purnima?
Dr. Purnima, are you there? No, ma'am, she's not there.
Okay. Uma? Dr. Uma.
Panelists, could you please put your videos on so that Jaya madam can watch you and see you? Yeah, thank you so much. Hello, Sridevi ma'am.
Dr. Uma? So then Dr. Sridevi.
Madam,
can you identify this?
Unmute, madam. Sridevi ma'am, unmute, please.
Ma'am, good evening, ma'am.
Good evening, Sridevi. Can you please describe the image? It is an image of...
Madam, it's a rudimentary horn, ma'am.
You find 2 uteri, right?
Ma'am.
Yeah. So it's a case of uterus diadelphus because
Diadelphus.
pregnancy is in this horn, this is enlarged and this is in normal size. Okay, then I went back to my pictures and I restudied them. I went to my archive. So now I can see a thin endometrial line in the same image, which I thought a solid right ovarian cyst. And this is the endometrium, which is causing an acoustic enhancement. So in pregnancy, diagnosis of Mullerian anomalies is very difficult, and thus is the message. So what is the presentation of Konuta? Kirana, please. Kirana, are you there? Kirana?
I don't see her, madam.
Okay. Then Prashanti. I can see Prashanti.
Yeah,
Shanti,
ma'am.
Vasudha, they are there.
Prashanti is there.
Pramoda
Yeah,
is
I'm there, ma'am.
How
Can
do
you
they
see me, ma'am?
present?
Ma'am, different age, different
No,
age groups.
what could
different-
be the clinical presentation in all age groups? What are all the clinical presentations?
They can present with, ma'am, they can present as such with primary amenorrhea at menarche age group, adolescents, I mean. Okay, they can present with like the first case you presented, like with cyclical pain or so on, primary amenorrhea. In the reproductive age group, they can present either with subfertility or recurrent pregnancy losses.
Yes.
In pregnancy, they can present with preterm, PTB, PTL, PROM, PPROM, and so on.
Even abruption.
Yeah, even abruption. Yeah. And in later post-reproductive age group, they can present with pelvic symptoms like chronic pelvic pain and so on, ma'am.
Yes, that's right.
Yeah.
And
Sometimes they present as persistent malpresentation, madam.
Yeah.
All the pregnancy.
Recurrent malpresentations, right?
I mean, it will be that breach that is always a breach sometimes.
Yeah, right.
Yes.
Right.
Yeah. And they can be asymptomatic also.
Also, right.
Coming to the dialogue proper. So
I just want to add one thing, ma'am.
Yes.
Recently had one lady, a primey. She was like 34, 35 weeks. She's been having pain like for a week or so. So we gave her everything to subside, but still the pain was continuing. And then later we induced her, but we could not get her into labor. And finally, we had to do an emergency Caesar. And then we found a thick septum right from fundus until the cervix. Oh, that was the intraoperative finding.
Yeah, dystocia is more common.
Dystocias are common.
Inertia.
Yes.
So that is why she did not respond to your induction.
Yes.
So the today's panel discussion will be under these headings. So let us start with embryology. Who will take this question? From what embryonic elements uterus and vagina develop? Padmaja, it's your turn.
The uterus and cervix and upper part of the vagina, they develop basically from the paramesonephric ducts or the Mullerian ducts, and the urogenital sinus part of it and the what we call these sinovaginal bulbs form the rest of it. So when they meet together and fuse, so that various anomalies are explained by either incomplete fusion, agenesis, or failure to formation from a solid column to a tube, failure of fusion, failure of resorption. So these will essentially decide how much is the problem.
Yes, very good. Thank you very much. Fallopian tubes, uterus, cervix, and upper 2/3 of vagina develop from part 1, that is Mullerian. Lower 1/3 of the vagina develops from part 2, that is sinovaginal births. So what is the embryonic timeline for development? Padmaja.
It is surprisingly pretty early because by the time of 20 weeks, the whole organ system is developed, and most of them by 10 weeks itself, their fate is decided. By the time we are seeing the fetal heart rate, by the time the other organ systems are developing, even the baby is getting ready for her reproduction.
Yes, that's nice. So it starts by 6 weeks and completed by 20 weeks. Let us see how does it happen. If the embryo is XY, the Y chromosome carries the SRY gene, So this SRY gene stands for sex determining region Y. So this causes testes to develop, which secretes testosterone, and this leads to persistence and differentiation of the mesonephric ducts. And testis also secretes AMH, and this causes regression of the paramesonephric ducts. So if the embryo is XX, so there is no SRY protein. So there is absence of testosterone, which leads to regression of mesonephric ducts, and absence of AMH leads to persistence of paramesonephric duct. Let us see the embryology. We have two Mullerian ducts which traverse to the midline, and they stop growing when they come in contact with the sinovaginal bulbs. So slowly the resorption starts, as you said. So the solid structure becomes a tubular structure. So coming to the urogenital sinus, the sinovaginal bulbs develop from the urogenital sinus. First, they form a vaginal plate, and then there is canalization of the vagina. What you have to remember here it is, resorption starts from caudal to cranial. So from caudal to cranial, the resorption starts. So whatever you see the anomalies, the first one will be the imperforate hymen. Then upwards, all the anomalies will be formed. So Conuta, what is the incident? The incidents. Anusha, are you there? Anusha?
Anusha, I can see on the screen, but she was, ma'am, operating, I think. When I called her, she was doing a hysterectomy. So let us, Dr. Vasantha is not in the panel, but
Baby Shalini?
Yeah.
no, she's also not there, ma'am. Dr. Baby Shalini is in a meeting, and Dr. Pramoda is there, I think.
Pramoda? What is the incidence of Conuta? Anybody can do. Prashanti, you can take.
Ma'am, in general
Ma'am,
population around.
Yeah, general population, it could be 5.5%, and if it is very most common is septate uterus, and then bicornuate uterus. Septate uterus, it could be up to 50%. It is septate uterus, ma'am.
Overall incidence.
Overall 7.
Overall incidence.
Overall incidence 30 to 40%, ma'am.
No. It's 4 to 7% in the general population.
5.5%.
And 6 to 7% in infertility clinics. So though incidence is very less, but it is very fascinating to diagnose Conuta.
Sorry.
Okay. So the embryological aberrations, as Padmaja told, we have developmental defects, fusion defects, and resorption defects. So first we deal with developmental defects. Among the developmental defects, Shama, could you please read out this for me? What are all the developmental defects? Shama.
Developmental defects could be uterine aplasia or agenesis, uterine hypoplasia, or unicornuate uterus.
So let us see one by one. Uterine aplasia or agenesis. So Dr. Pramoda, I think she has joined.
Yes, ma'am. I'm
Can you please describe this image? It's a 16-year-old girl presents with primary amenorrhea, and the USG shows absent uterus.
okay.
This is the urinary bladder, and what you see here is the right ovary. The uterus is absent. What is the probable diagnosis? Probable.
Maybe.
Yes.
Agenesis, madam. Uterine agenesis.
Yes, very good. The uterus is absent. What could be the DD? Is it anything else? So we have two things. One is MRKH syndrome. When the uterus is absent, you have to think of two things. One is MRKH syndrome, that is Mayer-Rokitansky-Kuster-Husser syndrome. And the second thing is AIS, androgen insensitivity syndrome. And how do you differentiate between these two things? We do a karyotype. Because you are seeing the ovary, it could be 46XX. So it is MRKH syndrome. If the ovary is absent, definitely you have to go in for karyotype, and that will be 46XY if it is androgen insensitivity syndrome. Okay.
One more thing about the androgen insensitivity syndrome is, madam, that they will not even have body hair. So they will be tall, they'll be beautiful, and there is no need of doing any waxing for them.
No androgen characteristics.
Yes.
But another bit of knowledge, they are those Thailand, all those dancers, na? They are all AIS.
Yes, they are castrated also. Castrated.
They are all about 7 feet tall, you know.
Gonad also will be abnormal, no, ma'am? Gonad location in androgen insensitivity syndrome, ma'am.
It need not be. They can have ovo test. They have a testis.
Yes, ma'am.
Undescended. Sometimes.
One more is Swyer syndrome also, ma'am. Ante for AS differential diagnosis, we can say Swyer syndrome.
So now we are talking about mullaria.
Okay, ma'am.
So if the uterus is absent, you can have remnants of the fallopian tube, or you can have the tube and you will definitely have the ovaries. Okay. Then we have finished uterine ablation. Next thing is uterine hypoplasia. Dr. Sridevi, you can take up this. It's a 20-year-old girl. She presented with primary infertility. On USG, you can see a small uterus. And how small is small?
Normal uterus is 8 centimeters, ma'am. Hypoplastic uterus is maximum 5 centimeters, ma'am.
Yes, it's almost half the original size.
Yes,
And one more thing, and here the measurements are 3 into 2 into 1.5 centimeters. And most important thing to say it is a hypoplastic uterus is the ratio between the body and the cervix. Normally this is
2/3 uterus and 1/3 cervix will be there, ma'am. In hypoplastic, reverse will be there like that, ma'am.
So in normal, the corpus is 2 and cervix is 1, 2:1.
Yes.
Whereas in a hypoplastic uterus, it is 1:1, or sometimes it is 1:2. Cervix is bigger than the corpus. Okay, we have finished uterine hypoplasia also. Then we'll see unicornuate uterus. So Padmaja, this is for you. It's a 35 years old female. She had 2 full-term normal vaginal deliveries, and now she presents with dysmenorrhea. Please describe this image. Padmaja? Dr. Padmaja?
She had to leave.
She has to leave.
She had to leave, ma'am.
Prashanti, you can take it.
Yeah. Ma'am, the image is showing uterine cavity. The shape of the cavity is like deviated to one side, that is banana sign.
Yes, very good.
So, though she had a full-term normal delivery, dysmenorrhea, typically they'll have unilateral dysmenorrhea like we learnt in our UG days. So, then we have to suspect a unicornuate uterus, ma'am.
So what are all the types of unicornuate uterus? We'll start from the right-hand side.
Technically speaking, unicornuate uterus rarely has full-term delivery. Very rare.
Yes.
We usually go into preterm.
Preterm labor.
Yes.
As the gestation age increases, the pregnancy increases, ma'am. Unicornuate. Initially, they get aborted. Later on...
Yeah, that's what madam also mentioned.
Yes, ma'am.
Very unusual to have 2 full-term normal deliveries. But this patient has 2 full-term normal deliveries. So Prashanti, let us describe these types of unicornuate. We'll start from the right-hand side. Please.
That's total absence of the other horn, ma'am. Unicornuate uterus.
There's no horn.
No horn, with no horn. Second one is with non-communicating horn.
With cavity.
No cavity.
Non-communicating cavity.
Rudimentary horn without...
seen, but there's no cavity.
There is no cavity. Horn is seen, there is no cavity. And
no
this
cavity. The third one is there is cavity, but there's no
Unicornuate
communication.
uterus with non-communicating
So the
rudimentary horn.
cavity
With
is
a cavity, but it is non-communicating.
Non-communicating rudimentary horn.
This
Yeah.
one?
With
The last
communicating
one is with
rudimentary
cavity
horn.
seen with a communicating horn.
What do you think out of this? Which one is dangerous?
Third.
Yeah. So non-communicating functional rudimentary horn is dangerous and very symptomatic. So these are all the various pictures, the typical banana sign. And this is a unicornuate with a gestation sac. So we'll move to the second part, the fusion defects. So what are all the fusion defects? Shama, can you please read out for me? Shama,
Yes, ma'am.
please read out for me.
Fusion defects could be uterine didelphys, biconjugate uterus, and atypical Overa syndrome.
Okay, we'll see one by one. First is uterus didelphys.
Didelphys.
Please read out this for me. Shama.
Uterus didelphys, there is a complete failure of fusion of Mullerian ducts, 2 uteri or 2 cervices, difficult for 3D rendering and 3D in trans-abdominal scan as well. And it is incidence is 5%, and sarclage should be there, and preterm labor could be placed.
Okay. So this is a case of uterus didelphys, and this is a trans-abdominal image. So I'll show you this video clip. So you'll have to describe this for me, Shama.
Yeah.
Please describe this.
Uterine didelphys.
You can see
it has a 2 separate uteri, 2 cervices, and there is a complete longitudinal this thing is there.
You can see
two separate uteri are there.
You see 2 horns of equal size. The endometrial echo is completely seen in both the horns, and they are very well separated by tissue. Okay.
Yes.
This is one more video clip for you.
Here as well, 2 separate cavities are there.
You again see this. Now you can see 2 cervices in this image. Here.
Yeah.
So the 2 cervices are clearly seen.
Yeah.
Well,
yes.
This is a 3D rendered image, transabdominal. TVS, it is not possible for uterus didelphys. We call this as H, figure of H shaped. So we'll come to the next part, the biconjugate uterus. Who will take up this? Biconjugate Sridevi? Dr. Sridevi, will you take up this?
Yes, ma'am.
Yeah. Please read out this for me.
Madam, biconjugate uterus, incomplete fusion of the Mullerian ducts, 2 uterine horns and single cervix.
We call this biconjugate unicornis.
Biconjugate unicornis, ma'am. 2 uterine horns, 2 cervices, 2 cervical canals, biconjugate bicolis, ma'am. 10% incidence. There is a chance of preterm labor and needs cerclage, ma'am.
Oh, thank you. You see this video clip and please describe this for me. You completely see this first. We'll watch this video.
Madam, uterus is seen with the endometrial lining.
Do you find any difference with the previous video and this video? That was uterus didelphys, and this is biconjugate uterus. Do you find any difference? Shall I play it again for you?
With a single cervix.
Madam, intervening tissue will be less, ma'am.
Continuation of endometrial lining.
Yeah. Yes, very good. So for biconjugate uterus, you see in the axial section, the endometrial lining is joining towards the cervix. This is the sagittal. You see the endometrium, sagittal. You lose the endometrium, and again you see the endometrium.
Okay,
in the sagittal. Endometrium seen, you lose it and you see. You see this in axial section. You see 2 endometrial and they are fusing.
Continuation. Okay, ma'am.
There is continuation of the endometrial lining in one part of the video, and whereas in the other part you can see 2 refringent endometrial echoes.
Okay, ma'am.
Whereas this was not seen in the video of uterus didelphys. Okay, do you agree with me?
Yes, ma'am. Yes,
so here, The endometrium is not fully separated. So now you see, both the endometrial linings are joining. So this is definitely not diadelphous. Okay?
Bicornuate. Okay, ma'am.
This can be septate also, that will come to it. So
Okay.
this is the bicornuate uterus after rendering. The only point is fundal indentation. We'll come to this later when I explain you about the measurements. So we'll come to the more interesting and more common part is resorption defects. So who will read this for me?
Shall I, ma'am?
Yeah. Prashanti, come on. Resorption defects are most common.
Resorption defects, which are most common, they are complete septum, incomplete septum, arcuate uterus, and atypical, that is Robert's uterus.
Okay. First, we'll see complete septum. So please watch this video. You see the endometrium, you lose the endometrium, and again you see the endometrium in sagittal section.
But shape is maintained normal. So this is where we miss generally, ma'am.
You can say that there's no difference between the previous video, what I have shown you for bicornuate, and this one. Is it so?
Yes, ma'am.
Both are similar.
Issue
right?
is there in between.
Okay, we'll see the axial video in the axial plane. Here also you can see two endometrial echoes separately.
And there is a continuity later. Yeah.
There's no continuity. You watch it again. The hypoechoic shadow is continuing throughout. That is a myometrium.
Yeah, right, ma'am. Two separate endometrial lining are seen.
So how do you differentiate between a septum and a bicornuate uterus?
The fundal
Yes.
dimple.
The fundal
Dimple. Rendering.
I'll explain you about the fundal indentation when I tell you about the measurement. Yeah, Sujata.
Madam, can I ask?
Yes.
Can I ask a question?
Yeah.
Madam, in bicornuate uterus, like the way you are describing, a bicornuate uterus will always have a single cervix.
No.
And for
bicornuate, bicollis, bicornuate, unicollis, both have.
Then if it has two cervices,
it is cervical canal. That's what I mentioned. A bicornuate uterus with two cervical canals with separated by septum. It cannot be a complete separate cervices. If there are two cervices, it becomes diadelphous.
Yes.
Okay.
A bicornuate uterus in which there is no communication with the endometrium at all, it becomes diadelphous. It is diadelphous basically, no? Because there's no communication. The two endometria are not communicating throughout the entire length of the uterus.
Yeah. That is the difference. We have one more thing called bicorporeal septate, where the endometrium is connecting. It all depends on the fundal contour. We'll come to this in measurements. Okay. Next thing is incomplete septum. Sujata, can you please take up this question?
Yeah.
This is an axial image and this is a 3D rendered image. Please describe this one.
Good evening, ma'am. Nice to connect with you after a long time.
Thank you.
Actually, when we are looking at a septum, the only diagnosis we can get it with the external contour of the uterus, and the depth of the septum, if it is not reaching completely till the lower part of the uterus, that is when we say it as a partial.
No, please describe these images. This one.
Yeah. So this is a
This is a 2D image and this is a 3D image. You translate these findings into 3D.
So the 2D image is showing two different endometrial cavities which are separated by a band of myometrium. So we will have to look at this point of time as thinking that it could be either a complete septum or a partial septum or a bicornuate uterus, because this is a single image where we can only just see two cavities. But when we render it into a 3D image, we can identify that the external contour is smooth and so that is eliminating our possibility of having a bicornuate or a didelphys uterus. So then when we go down in the 3D image and measure the depth of the septum, it is not extending completely up to the lower uterine segment, so there is unification in the lower uterine segment, so we have to tell it as a partial uterine septum.
Very good, very good. Thank
Partial
you.
incomplete.
So the implications of septal size. So please read out this for me, Sujata.
Yeah, the septum, if it is dividing 2/3 of the uterine cavity, it has got more complications. The septal length has to be measured, and the remaining length also has to be measured. The more deeper the septal length, probably the complications are more.
No, it is the other way.
It is the other way.
A partial septum causes more complications. A
Okay.
thick septum causes more complications because a thick septum has more blood supply. So the septum is not a good thing for implantation. So for infertility specialists like you, so we need to give the length of the septum and also the length of the remaining cavity.
And also the total breadth of the horizontal interosteal diameter also is what we see.
Okay, these are all the various images. This is a partial septum, again a partial septum, and this is a complete septum with a one horn lodge. This is again a complete septum. How I am telling that it's a complete septum? The fundus is round, convex. This is a complete septum extending up to the external os. So this is not a septum. This is an arcade uterus. So we'll see it later. So the atypical is Robert's uterus. So we'll see the arcade uterus. So this is what I have told you. There is a septal indentation. This is called bicornuate because the uterus is single. So we have the septum, the fundus is convex. So this is what we have to see in 2D. This is what I was telling. You see the endometrium continuity in sagittal image. Then you lose the endometrium and again you see the endometrium. So in both the things, it is same. Both the things it is same. You see the endometrium, you lose the endometrium, and again you see the endometrium. So that is what signifies the bicornuate or the septate uterus. So then we'll go for diagnosis. So that what are all the diagnostic modalities? Shama, this is for you. Am I missing anybody?
Modalities could be transdermal.
One second. Am I missing any panelists? Or I am including everyone?
Madam Anusha, have you joined? No.
Vasudha?
Panel, you're most welcome. Padmini ma'am is there. Vasudha ma'am is there. Savitri ma'am would like to join the panel, you can. Narsavni ma'am would like to join the panel.
Padmini. Dr. Padmini, are you there?
Yeah, ma'am. Yeah, I am there.
Could you please read out these diagnostic modalities for me?
Yeah. The diagnostic modalities is transabdominal sonography, and then comes the transvaginal sonography, and then the 3D volumes, and then sonohysterosalpingography, and gel vaginocervicography, and MRI. So, I feel...
Yeah, please continue.
And then whenever you suspect the connuta,
when do you suspect
connuta? That is when the uterus is not in the midline, and usually it is a broad uterus, and then the axial endometrial reference has two separate uteri, and then varying length and endometrium on the sagittal sweep.
So among all these things, most important thing is endometrial reference as two. That's what I told you in the video clips. The endometrium refringes as two.
Yeah. Okay. You can see two and then connected by the tissue, or it may be close together.
So I'll take up these things. Diagnosis. The step one is you have to optimize your 2D image. So how do you optimize 2D image? You have to increase your 2D gain. Usually for gynec ultrasound, we decrease the 2D gain. So for 2D optimization, that is for 3D volume, you have to increase your 2D gain. You select the 3D button and you select the render or multiplanar plane. You adjust the ROI. This is very important. So for this, you have to include the area of only desired anatomy. If you want to render the uterus, you have to render only uterus, not the ovary or any other thing. Otherwise, you don't get a good 3D volume. So this is what I was telling. For routine gynec ultrasounds, we decrease the gain. For 3D, you have to increase the gain. Here the gain is 6. Step 2.
Jaya ma'am. Jaya ma'am.
Yeah. Yes. Yes, Monica.
Jaya
Yes.
madam.
Yes, Monica.
Hello.
Yes.
Jaya madam.
Yes, yes.
The audio is, madam, your audio is breaking. Some net. Madam, your internet is breaking. The voice is breaking.
Even now? Even now?
No, now it's better. Now,
Okay. Okay.
so better now.
Okay. Shall I repeat the previous slide or is it okay?
Yes, ma'am, please repeat.
So for optimization of 2D image, you have to increase the 2D gain. Select the 3D button, select the render or multiplanar. You adjust the ROI, you should include only the area of desired anatomy. So this is the thing. Usually we do 2D with low gain. For 3D, you have to increase the gain. And step 2, 3D volume acquisition. How do you acquire this? So volume angle should be 120 for uterus. Quality should be made maximum. You ask the patient to hold breath and not to move. You press the start or freeze button and save the volume. If you want to take an additional volume, you select the vol pre for a second volume. So this is the thing I am telling. So the angle must be 120 for uterus, quality maximum. So if you take 120, you include both the cornu and include from the fundus to the cervix. If the uterus is very broad, you can take 2 volumes for the uterus and the second volume for the cervix. And if you want to take a second volume, you have to press this vol pre button. So then you have to use all these knobology. And step 3 is post-processing of the volume. So here what you have to remember is the green line must be in line with the endometrium. Here this is a raw footage. So I have adjusted the green line to the endometrial line and you can see how nicely there is the 3D image along the 2 coronal tubal openings are also seen. This is a surface mode, this is HD line and this is silhouette mode. So you can use all the things. So you can also use the OmniView with the VCI where you can see even the endomyojunction very, very clearly. So what are all the diagnostic limitations? Shama, can you please read out this for me? Shama?
Diagnostic limitations, adenomyosis or myoma, they distort the shape, and very careful in such cases we have to be, and take 2 or more volumes scans as possible, and in pregnancy much more cautious.
So I've just shown you the case of uterus diadelphus. So in pregnancy, it's very difficult to diagnose Mullerian anomalies. Adenomyosis and myoma, they distort the shape of the uterus. Even rendering is very difficult. So for these cases, you may have to take separate volumes for cervix. So for vaginal malformations, gel sonovaginography sometimes has to be done. So for unmarried, if there is a double uterus or the patient or the uterus is in mid position, you have to go for transabdominal acquisition. And whenever you find a Mullerian anomaly, what you have to look for?
Renal anomaly.
Renal anomaly.
For every case, you have to look for renal anomaly. So even transvaginal sonography is not sufficient for some cases because there is a restricted field of view. If the uterus is very broad, then you have to go for transabdominal, patient habitus, bowel shadows, a mid-position uterus, all these influence your 3D acquisition. And moreover this, myometrial contractions, sometimes they distort the shape of the uterus and may look as Mullerian anomalies. So what is this uterus? So Dr. Padmini, what is this uterus? How does it is looking?
It looks like
Septum.
septum. Yeah, there is a septum in between. Yeah.
Broad septum.
So after 15 minutes for the same patient, this is the image. Now it looks
This
like
arcuate. Arcuate.
So
It looks like arcuate.
myometrial contractions always mislead the sonologist. So whenever there is a subtle diagnosis, you definitely have to repeat your scan. So what is this image looking like?
This is a T-shaped
Yeah,
uterus.
exactly looking like a T-shaped uterus.
Yeah.
After 30 minutes, this is the image. It's a normal uterus.
Normal.
This is again a misleading thing of myometrial contractions. So what is this?
So much of difference with myometrial contraction, madam.
Yeah. And this image?
It looks like adenomyoma.
Yeah.
It is having
Yeah.
unequal anterior and posterior
And
vagina.
posterior.
So after 15 minutes, same uterus.
This is a, yeah,
It looks like adenomyoma of the anterior wall.
anterior wall.
Yeah, this is what the myometrial contraction. You should always be cautious before you put your final diagnosis. So getting a mid-sagittal section is a challenge in Conuta, which is very much required for 3D rendering. And green line has to exactly pass through the endometrial line. Otherwise, you don't get the shape. Sometimes it may look as a unicornate uterus also. And your green line exactly has passed through the common cavity in case of a septum, which is very, very difficult. Even more difficulty if two horns are not in one plane. So in such cases, so a full bladder and transabdominal sonography may help the sonologist. So please read out this for me about the MRI. Padmini.
Yeah, MRI is a good 3D volume is equal to MRI, useful in complex anomalies, cervical and vaginal anomalies, and for the location of the rudimentary horn in pediatric cases. And MRI is useful in mid-positions uterus.
So
but ultimately, nowadays, whenever we are suspecting, we are going for an MRI, especially in young girls, we prefer MRI the best.
That is what I do for pediatric case. Whenever you can do a very good 3D transvaginal sonography, the 95% of the Mullerian anomalies are diagnosed unless they are complicated and cervical vaginal, which cannot be rendered by transvaginal sonography. So nowadays, the 3D volume is almost replacing MRI. MRI is reserved for complex and cervical and vaginal anomalies, as you have told, in unmarried or pediatric cases. So we have finished 2 topics and we'll go to the measurements, which is a difficult and confusing topic. I think I'll make it easy for you. So we have so many measurements: lines, angles, contours, thicknesses, and ratios. So how to proceed? So what the thing is, you have to use every measurement in your machine. So let us see the lines. Shama, can you read out this for me? The lines. We have 3 lines.
Okay. The lines are interosteal line, line joining the ostium and internal os, and the line joining fundus and interosteal lines.
So let us see how these lines look like. This is interosteal line. This is the
interosteal lines.
This is the line joining the second one. Ostium to internal os.
Internal os.
Internal os.
Third line is from the fundus to the interosteal line.
Interosteal.
I think I am clear. If you have confusion about these lines, the next part of the presentation will be difficult for you. The interosteal line, the line joining the two ostia, the line joining the ostium and the internal os, the line joining the fundus and the interosteal line. Okay?
Okay.
So then we'll go to contours. One is external fundal contour and the second one is internal endometrial contour. So we'll translate this. So normal external fundal contour. So we have 2 contours. What are they? Convex fundal contour and flat fundal contour. These two are normal because there should not be any indentation in the fundus. It can be convex or it can be flat. This is considered normal. So this is what? This is a convex fundus and this is? What is this?
Flat.
This is a flat fundal contour. So both these things are normal. So we'll go to the abnormal external fundal contour. This is the interosteal line. How do we measure? We measure from the fundus to the interosteal. So this should always be more than 5 millimeters. So 5 millimeters is the cutoff. It should be more than 5 millimeters. Then that would be normal. Anything less than 5 millimeters is abnormal. So we'll see. This is the Traiano and McCarthy's method. So from the far right hand side, who will take up this? Sujata. Please, the measurement has given in this image. It is more than 5 millimeters. From the interosteal line to the fundus, this is more than 5 mm. So this is
normal.
This is normal. So here there is a fundal indentation and you have this green line as the interosteal line. So the line between the fundus and the interosteal line is, here it is less than 5 mm. So this is abnormal. And here
it is crossing the interosteal.
It is crossing, the fundal tip is crossing the interosteal.
Interosteal.
So these two are, what are the names of these two you try? This one and this one, fundal dip.
Bicornate. Bicornate.
Very good. Bicornate. So if this dip reaches here, what is this?
Didelphys.
Didelphys. Very good. This is called Traiano and McCarthy's method for the external fundal contour. So then we go to normal endometrial contour. So we have a slightly
Didelphys.
concave. What?
Man, that was not didelphys, means the two cavities are separate. No? Didelphys.
That's what I told you. This fundal tip reaches up to the external arm.
Yes.
So then that becomes didelphys.
Right.
So we have 3 types of normal endometrial contour. One is, this is slightly concave, completely flat, or slightly convex. These are the 3 types of normal endometrial contour. So we'll translate these line diagrams into ultrasound images. This is
concave.
Slightly concave.
Slightly.
And this is
Flat.
And this is
Slightly convex.
Convex. Yes. So abnormal endometrial contour. So again we compare this with the interosteal line. The red line here is the interosteal line. So the distance between the interosteal line and the endometrial contour we measure. So if it is less than 10 millimeters or more than 90, this is considered as normal. If the distance between the interosteal line and the endometrial line, this is how we measure. And this is normal because it is less than 10 and more than 90. And what about this? The distance between the interosteal and the endometrial contour is
more than
10. And angle is less than 90. So 10 and 90 are the cutoffs. More than 10 and less than 90 degrees is abnormal. Okay?
And it is
yeah, we'll see these images. And Sujata, I think you can interpret this. What is the first image?
The first image is slightly.
The fundal contour?
Fundal external contour is normal. The internal contour is slightly concave.
So this is
normal.
The fundal contour
is external contour is normal, and internal contour is also, like, we have to draw the interosteal line. If
So,
it is more than,
I'll tell you that it is less than 10 millimeters and more than 90.
If it is less than 10 millimeters, it is normal.
So this can be an arcuate uterus. So the third thing.
The third one is external contour is normal. And the internal contour, the indentation is more than 10 millimeters and it is acute, less than 90 degrees. So it could be a septum.
Subseptate. Because it is incomplete, it is an incomplete septum. And this one?
Here we have the external contour is normal. The internal contour is dipping down and it is more than 1 centimeter till the internal loss it is going. It could be a complete septum.
Septum complete. And what about this?
Here we have the external contour which is dipping down and reaching up to the internal interostitial line.
Yes.
So the distance is less than 10 millimeters.
5
millimeters. And the external contour is also, the internal contour is also dipping below the interostitial line and it is acute and more than 10 millimeters. So this is also abnormal. So this could be a biconvex uterus because we are having the external contour problem.
In all the other images, the fundal contour is normal. Here we have fundal indentation. So this goes into biconvex uterus. Very good for the interpretation. So this is the arcuate uterus. This is a subseptate uterus. And this is a complete septum. You see the fundal contour is completely convex in all these 3 images. So we'll go to the angles. Who will take up this? Prashanti. Please read out
the angles. There are 3 angles. Internal endometrial angle, lateral endometrial angle, and the T angle.
Okay. So the first one, please read out.
The first one is internal endometrial angle. That should be less than 90 degrees.
Less than 90 degrees. I have put this in red. Red means abnormal.
Abnormal. Okay.
Less than more than 90 is normal.
Normal. Less than 90.
That's what we say for arcuate uterus.
Okay.
More than 90. So less than 90 is abnormal.
Abnormal. Then the lateral endometrial angle less than 130 degrees is abnormal. Then the third one is T angle less than 45 degrees abnormal.
Yeah. You have to remember 90, 130,
130, 45.
45. So the thickness. Please take up this.
The thickness, we measure myometrial wall thickness and the lateral wall thickness.
Okay, we'll see how we measure it. So you can take it in a 3D image also. We sum up the anterior thickness and posterior thickness. And we calculate by dividing 2. Or otherwise, you simply take a 3D volume and measure from the fundus to the
endometrium. Interostitial line.
So that should always be more than 5.
More than 5 millimeters.
So less than 5 millimeters again goes to a fundal dip. Okay, the lateral thickness. We measure lateral thickness from the lateral farthest part of the lateral wall to the angulation from the lateral wall. So this is called lateral wall thickness and this should always be less than 7 mm. Okay?
Okay.
So I'm just skipping off these ratios. Otherwise, I'll be confusing you very lot. So we'll go to the types of anomalies. So we have already described many of the anomalies and we'll revise in the ending. So we'll go to classification. So what are all the classifications? Anybody other than these people? Uma?
Ma'am, shall I read out, ma'am?
Yeah. Sridevi, come on.
Types of classification, ma'am. ASRM classification, ASHRAE and ESGE classification. And another is CUMU, ma'am. And another one is ACI, EMS and ACU, ma'am. ACU, AM classification, ma'am.
So there are so many classifications, more than 5. But usually what we follow is the ASRM. ASHRAE SJ is the latest and the perfect classification. We'll see how we classify. So this is the old version of ASRM classification. And this is the new version. I think you all know that even arcuate uterus is included. Even the abnormalities, cervical and vaginal abnormalities are included. And we have also included bicorporeal septate. Okay. This is what we have already discussed. This is the ASHRAE SJ, the perfect classification, but it is very difficult for the clinician to understand. So for reporting, so far as now we follow only ASRM classification. So this is how the ASRM, the ASHRAE SJ classification is there. It describes the uterine anomalies, cervical, vaginal, and also there is a class for unclassified malformations. This is a Perfect classification. It also recommends to give a drawing of the anomaly. So let us compare bicornuate, septate, and arcuate uterus. And Monica, this is for you. Monica. She's not there. Monica, are you not there? Who will take up this? Who will take
I'll take up, madam.
Yeah. Padmini.
And then indentation of the fundal control. In case of a bicornuate uterus, there is an indentation of the fundal control. And whereas in a septate uterus,
Can you please tell me the measurement of the fundal indentation? What is abnormal?
more than 5.
Less than.
Sorry, less than 5.
Less than 5.
Less than 5, yeah. And then in a septate uterus, it is absent, indentation is absent. And even in an arcuate uterus, the indentation is absent. And then fundus to endometrium distance, in a bicornuate uterus, it is less than 5. Whereas in the septate uterus, it is more than 5 because the indentation is more, and arcuate uterus also, it is more than 5.
Indentation is less. There is no actually indentation.
Yeah, arcuate uterus.
These two things are same.
Yeah.
The first and second things are same.
And then endometrial angle, whereas in a bicornuate uterus, it is not there. Yeah. And in case of a septate uterus, it is less than 90. And then whereas in arcuate uterus, it is more than 90. And then endometrial indentation in a septate uterus, it is more than 10 mm. And then whereas in arcuate uterus, it is less than 10 mm.
I think it is clear for everyone. I hope so. So then we come to the reporting. So
Ma'am, one small doubt, ma'am.
Yeah.
Ma'am, indentation, how to look for, ma'am? Less than 10 mm, more than 10 mm, endometrial indentation, ma'am?
Endometrial indentation is different from fundal indentation.
Fundal indentation.
Fundal indentation should be more than 5 mm. Endometrial indentation should be less than 10 mm. That is normal. The two things are separate. Fundal indentation is different from endometrial indentation.
Can you go back one slide for a moment? Yeah, thank you. No, next slide. The briefing, ma'am. The table.
This one, huh?
Next. This one. Yeah.
So,
the previous one, table.
This one,
Yeah.
ma'am.
Yeah, thank you, ma'am.
Yes.
I've already shown you the line diagrams about the fundal indentation.
Yeah.
So this is it. This is fundal indentation. This is endometrial indentation. So here the fundus is normal, but there is indentation of the endometrium. Here the fundal indentation. Sridevi, is it clear for you? This is normal fundus. There
Yes,
is
ma'am.
no fundal indentation. Here you see the fundal indentation. So this should be more than 5 mm to say it is normal. This is endometrial indentation. This should be less than 10.
Less than 10.
Less than 10.
Is it clear? I think it's clear now.
Yes, ma'am. Now it's clear, ma'am. Yes, ma'am.
So we'll go to reporting and I'll read out this for you. So first you have to mention the size of the uterus. If there is fundal external contour abnormality, you measure it and you mention the measurement. And then comes the endometrial contour. If there is any indentation in the endometrial contour, you have to measure the depth and also you have to give the angle. If you find any septum after measuring everything, then you mention it whether it is complete or incomplete. You have to mention the length and thickness of the septum and also give the measurement of length of the remaining cavity. If the septum is very thick and this patient goes to an infertility clinic, you have to do the Doppler study and also you have to give the ORI of the septal vessel. If this is an unicornuate uterus, you mention whether it is right or left, and if the rudimentary horn is there, you have to mention and you have to describe the rudimentary horn also. If there are associated cervical and vaginal anomalies, you mention them, you describe them, and finally, you have to give a line diagram of the anomaly, what you are reporting, so that the clinician will clearly see the picture, though he is not doing the scan. So this is the reporting thing. That's what I've told you. You have to draw the diagram, says the X-ray SJ. Otherwise, your reporting is incomplete.
Madam, in peripheries, nobody is giving this type of a report, madam. They just suggest further investigation is MRI. That's all.
MRI.
We are not getting any, not even half of the reporting what you have suggested. We are not getting even less.
From
half.
today, you yourself start giving reporting like this. Then the
You
other
do
person.
yourself now.
But I don't have a
Padmini
3D.
ma'am, you have
We don't have. I don't have a 3D scan, madam. That's the thing.
So then you ask your sonologist to give a reporting format in this way.
Yeah.
He-
Nobody gives, madam. They just write suggest MRI. That's all. Your reporting is so excellent. So as you told, by seeing that we know the plan of action.
So this is the final workflow of the Mullerian anomalies. I think you are not seeing this properly. So we'll go by segment. So who will take up these things? So Monica, I'll give this question to you.
Yes, ma'am.
Yeah. So first you do a scan, pelvic scan. You look for a uterus. What do you do if the uterus is absent?
Uterus is absent is hypoplastic or aplastic uterus?
Not hypoplastic.
Aplasia, uterine, aplastic uterus.
So what is your
MRKH or androgen
insensitivity syndrome? So
AIS.
So what do you do?
Yeah.
Next test is karyotyping.
Karyotyping.
So for MRKH,
Karyotyping. In MRKH, we'll have an XX karyotype. In AIS, it's a male karyotype, XY.
so we have finished absent uterus. Then we'll go, if the uterus is present, what we will do? Next.
If the uterus is present, we have to
You
first see whether the
size
uterus,
of the uterus. Size of the uterus.
Whether it is in the midline or not.
No.
Whether in a single sweep we can see.
You see the size of the uterus. So if the uterus is small,
Yes, size
and
of
the
the
uterus is normal. What do you do if the uterus is small? What do you call it?
If the uterus, it is hypoplastic uterus, less than 5 centimeter in the longest dimension.
What is the
And
karyotyping?
karyotyping is 46XX.
Exactly. So we have finished hypoplasia. Then we'll see what is a normal uterus. So here the size is normal. Then we look for single cavity or double cavity. So who will take up this one? Prashanti?
Yeah, ma'am. Assessing cavity, if there is a single cavity, then look for shape of the cavity. If it is banana shaped, then it is unicornate uterus. Or whether it is banana shaped, T-shaped, or triangular shaped.
So we'll go to banana shape.
Banana shaped.
We call it unicornate.
Unicornate uterus.
And what will you look for if you find
Then
it?
check.
What
If there is
will you look for?
unicornate uterus, check for the other horn. Whether it
There is no horn, no
horn.
problem.
No
So if
problem.
you find
If
a
there is
horn,
a horn, then check whether there is endometrial cavity lining.
no cavity, no
Like presence
problem.
of cavity or no
The
cavity, no
cavity is
problem.
present.
Then check whether it is communicating or non-communicating.
So non-communicating functional functional rudimentary horn is a problem. Okay. We have
Madam, I have one question. I have one question, Jaya ma'am.
Yes.
Madam, in a unicornate uterus, I've seen many times, it's difficult to scan the cavity. It is deviated on one side. But there is a patient who delivered. I did IVF on that patient. She delivered and she had 2 tubes. She had 2 ovaries.
Yeah, she'll have.
True.
And she had
Mullerian ducts are nothing to do with the ovaries. Both the ovaries are seen. That's what I've shown in the uterine aplasia also. If the
But ma'am,
uterus
I remember drawing a picture of unicornate uterus in embryology wherein the fallopian tube should rise from the tip of the fundus. And there is 1 tube and 1 ovary. I remember making that diagram in embryology.
Not the tip of the uterus. It starts with uterine fallopian tubes. Starts from the fallopian tubes, then comes the uterus, it canalizes, then the cervix, then the vagina. That's how the Mullerian ducts form the uterus. Not from the tip of the uterus. It is the starting point of the Mullerian duct.
So unicornate uterus will always have 2 ovaries?
Yeah, definitely.
Yeah.
Definitely.
Is there any case where
embryology is completely different?
Is there any instance where unicornate uterus has got one tube and one ovary?
Unicornate uterus will have one tube, two ovaries.
Yes. Okay, ma'am.
Okay.
I'll
So
have
we have finished banana shape. So we'll come to T shape. So the requirements of the T shape.
T angle less than 40.
Sorry.
Lateral angle less than
Less
130.
than 130.
And lateral wall thickness should be more than 7 millimeter.
Yeah. So we have finished
Triangular cavity.
banana. We have finished banana, T shape, and
T-shape
triangular
and
shape.
triangular cavity.
So if the uterus is showing triangular cavity, what do you look for?
The fundal
Look for
contour. That is
external fundal contour.
fundal contour.
So I give you that fundal contour is convex. So then what will you look for?
Septum.
Endometrial contour.
The
Yes.
distance of
So
the
then you look for endometrial contour.
Endometrial
If the
contour.
fundal contour is normal in a triangular cavity uterus, fundus is normal, then you look for endometrial contour.
Endometrial contour.
What are the probabilities you have in endometrial contour?
Flat.
It can be flat or slightly
slightly
concave.
concave.
Then this is a normal uterus.
Normal uterus.
Okay. Then you come for abnormal endometrial contour.
dipping.
If it is more
Dipping.
concave.
Then what do you do? What measurements you do?
From fundus to interosteal line, we have to take the measurement.
Not
As
from,
less-
not from the fundus.
Depth of the
We are,
endometrium.
Or depth
we are
of
talking
the
about the endometrium. From
Yeah,
the interosteal line to the endometrial tip.
To the tip of the endometrium.
And
Or
also
deep-
you have to look for the angle. The angle is more than 90 and the thickness is less than 10
thickness is
millimeters.
1
What is this?
centimeter.
Normal. Arcuate.
Arcade
This
uterus.
is arcade. And SRSJ says arcade uterus is normal, a normal variant. So
Normal.
whenever you write arcade uterus in your scan report, you have to mention in brackets that it is a normal variant. So if the angle is less than 90 and the thickness is more than 10 millimeters?
Biconvate.
Bicornate.
No. I've told the fundal contour is normal.
Oh,
septate.
fundal contour is normal. Septate. Septate.
Septate.
Yeah, it should be a septate.
Septate.
So you have to think of the septum in triangular cavity and also in double cavity. So we'll come to double cavity. Who will take up this? Vasudha? Shama?
Yeah, I'm here, ma'am. Vasudha here.
Vasudha, come on. So I give you a uterus with a double cavity. What do you see? So we look for external fundal contour. Okay,
Yes.
I say that this is a uterus with normal external fundal contour and having double cavity. Fundus is normal, but the
Okay.
cavity is double.
Yeah.
So
So
it
that
can
is the
be-
complete septum.
It can be a complete septum or
Septum
incomplete
or
septum.
incomplete septum.
So now I give this scenario as there is fundal indentation, a double cavity with fundal indentation. So what do you think of?
That can.
So if
So
the
the right
indentation is
bicornate to
complete,
arcuate to.
no, I'm giving the
Bicornate.
scenarios. A double cavity with fundal indentation, and this fundal indentation is complete. That is up
The
to the
bicornate.
internal os.
That's a bicornate uterus.
Complete indentation. Complete indentation gives you
Didelphus.
two uteri.
Yeah, uterus.
So
didelphus.
complete fundal indentation gives you two uteri. So that we call uterus didelphus. So if the indentation is incomplete,
Biconvate.
so if the fundal
Bicornate.
indentation is incomplete, it can be a bicornate uterus or it can be a bicorporeal septate. This is the new inclusion in the classification. That means it fulfills all the criteria for the incomplete indentation, and also it has a septum up to the internal os. This is bicorporeal septate. Or otherwise, with simple fundal indentation, you can name any uterus as bicornate. I think I am clear here.
Yeah.
Okay.
Yeah.
Ma'am, can you show a diagram of bicorporeal septate?
The first thing I have shown.
I mean,
I'll tell you. Yes.
Yes.
This is the bicorporeal. So there is fundal indentation. You see incomplete cavity. So this is partial partial septate and partial bicornate. Sorry. This is indentation.
Which
very
one,
much.
madam? Which one? There's
This
no cursor.
Okay. Sorry. So I'll have to go in for. Sorry, I have to go in for my full screen. So this is my pointer. So this one. There is fundal indentation, right?
Yes.
So if any type of fundal indentation, that is bicorporeal uterus, okay?
Yes.
Okay.
So if the fundal indentation is complete but not with the cervix, so this is bicornuate uterus, what you are saying. If the indentation is complete but the septum is extending, this is bicorporeal septate.
And Adam, in this classification, where is diadelphys?
It is not there.
Second page. It is not there here.
It is not there.
So it's not there in the ISG.
Yeah. It's not there.
Because I have read somewhere that they have done away with a few terminologies, ma'am. I'm not sure.
This is the new one. That
Yeah.
was bicorporeal septate.
But why have they done away with diadelphys? This means complete biconnuate. They are making it same as diadelphys, ma'am?
No, biconnuate is completely different from diadelphys. Both are not same.
And diadelphys is not there in the current terminology, as far as I can
It is
remember.
there in the second page, I think.
I'm not an expert, but I don't know,
It is
ma'am.
there in the second page, I think. They start with only normal cavity. The classification starts from normal cavity. So we'll go to rare anomalies, the Ovira, Roberts, and Acom. So Ovira, who will read out this for me?
Ma'am, I'll read.
Yeah.
I'll read it out.
Ovira is atypical uterus diadelphys, wherein we have got obstructed hemivagina, ipsilateral renal agenesis. So the first letters make up OHVIRA.
So there is a septum, there is a blind
There
vagina,
is
there is obstruction and ipsilateral renal agencies. That's what I told you. Whenever you find a Mullerian anomaly, you have to definitely look for renal also. So this is very difficult in ultrasound, routine ultrasound. So for these rare cases, we sought for MRA. So this patient presents with severe dysmenorrhea and this septum requires excision.
Madam, one more question. This obstructed hemivagina is always on the same side as the missing kidney?
Yeah, that is why they have called it ipsilateral.
Okay, same.
Ipsilateral. So the
Yes.
name itself implies it is ipsilateral
Same side.
renal agenesis. So that's
Right.
why this at the right side there is obstruction and right kidney is absent. So the Robert uterus. Anybody can take up this?
Yeah, I'll read it out now.
Yeah.
Robert's uterus, it's a asymmetrical septum, obstruction of blind end, progressive dysmenorrhea, difficult in ultrasonogram, and we need MRI, and we will have to do the resection of the septum.
So usually what we have seen so far is the septum is coming down.
Yes.
Isn't it?
Yes.
Because the two Mullerian ducts are meeting in the midline, whatever the septum is, whether it is complete or incomplete, must be in the midline. But here it is a asymmetrical septum. It is towards one end. That's why this end is blind. Again, all the menstrual blood collects here and again she'll have severe dysmenorrhea and this dysmenorrhea is progressive. So this case also needs surgery. Okay, coming to Acom. This is very, very
How do
interesting.
you resect the septum here, madam? It is not in the center, no?
Hysteroscopic resection.
Hysteroscope, and you have to go to one side and then do.
Yeah.
Okay. Okay.
So who will read this for me? Acom?
I'll read, ma'am. Accessory cavicated uterine malformation, ma'am. It is an atypical Mullerian anomaly. Here she'll be having a progressive dysmenorrhea, difficult to diagnose in ultrasound. MRI can be done, ma'am. And the treatment is the resection of the septum, ma'am.
So in 2D ultrasound, you will see only a cystic space. You can't say that it is Acom. So MRI is the only diagnosis for Acom.
And what is the embryology of this? How does it form?
Some remnants of the Mullerian duct are persistent in this part, I mean the right side of the uterus. So some parts of the Mullerian remnants, but here the uterus looks normal. There is complete canalization also, complete resorption of the septum. But some Mullerian remnants are within the uterus, the remnants. So they start functioning and they produce endometrial fluid, they start menstruating and thus ends up and severe progressive dysmenorrhea.
Right.
So the DD for progressive dysmenorrhea in adolescents. Number one, so far we are telling the functional non-communicating cavitatory rudimentary horn is the number one for DD. Number two is Robert's uterus. Number three, Ovira syndrome. Number four, ACM. And number five, JCA, juvenile cystic adenoid malformation. This image we have shown in Sonal's presentation. She was showing the cystic adenomyosis. So all these five things you have to remember. If in case a young girl comes with progressive dysmenorrhea and your ultrasound is not related to the symptoms of the girl, then definitely you order for MRI and you'll get your definitive diagnosis.
Endometriosis is not a DD, Jaya ma'am?
Yeah, that's what I told you. Cystic adenoid malformation. Cystic adenomyosis.
Okay.
This is cystic adenomyosis, JCA.
Right.
So these are the three things: juvenile cystic adenomyoma, Robert's uterus, and functional non-communicating rudimentary horn. These are the final three DD.
Madam,
which are not amicable to 3D acquisition.
Madam, nowadays in these gynec groups, they are posting pictures of adolescents having rectal nodules of endometriosis.
Yes, yes.
First of all, does it exist? Do cases come and the presentation will be same like severe progressive dysmenorrhea and rectal symptoms
Yeah,
also?
they have continuous pain. Not only dysmenorrhea, rectal nodule will have continuous pain every time she defecates.
So, ma'am, I'm asking you, suppose this girl is 18 or 19 years old. How much time does it take between her menarche and formation of the rectal nodule? In 2.5, 3 years, the nodule starts forming, ma'am?
We can't say. It all depends on the endometrial tissue the rectal nodule is having and how functional it is. The presentation may depend. We can't say that.
Okay. Thank you, ma'am.
Okay. So we'll come to the end of my presentation, the epilogue. So I give this take-home message, the Panchasutra mantra of Mullerian anomalies. So number one, start with transabdominal sonography. Whatever I have told you, that sagittal endometrial sweep, everything. You start with the transabdominal ultrasound. And 3D TVS is the gold standard. And 3D coronal for Conuta, provided you have a good 2D image and you have a good 3D volume. Number four, MRI for cervical vaginal anomalies and also for complicated anomalies. And for the last three, just we have completed. And number five, first and but not least, know your machine first. Unless you know your machine, the knowledge, the acquisition, image optimization, you will never diagnose Mullerian anomalies. Conuta, the mistakes in the creation of God, the Almighty. We as surgeons sometimes prove ourselves greater than Him by rectifying these mistakes. I think all the panelists will agree with me. So I am honored, Monica. I am obliged. Thank you for this opportunity. This is a great day for me that I've shared the dais with my teacher, Dr. Sonal, and this Dr. Jayavarthi signing off. Thank you very much.
Madam, HSG also is one type of a diagnostic tool for diagnosing the anomalies. No, like arcade uterus, like bicornate, we can because
not at all. HSG will not give you the fundal contour.
Yeah,
In
those
case-
all they never used to, we never. But before the era of scans, when we were PGs and all, we were taught that HSC because that time there was no scan and all, and then 3D scan or a 2D
Yeah,
scan or a
those
transvaginal.
days
We used to do
make
HSC
mistakes.
also to diagnose the like a bicornuate uterus or
Yeah,
a
we used to do mistakes.
yeah.
All the septate uteri would have been arcuate uteri.
Yeah,
Oh.
yeah. But that
all
when
the bicornuate uteri can be complete septum.
septum,
So
yeah.
without fundal
yeah.
contour, you cannot classify Mullerian anomalies.
Yeah.
Okay.
That's
Yes.
true. But
The
before the era of the scans, we used to do for infertility cases, we used to routinely do a HSG for identifying and then for tubal testing. Before the era of scan, what I mean.
Rough diagnosis.
Yeah.
But 3D ultrasound and rendering and volume measurements have totally revolutionized diagnosis.
Yeah.
3D.
3D. So, Jaya ma'am, I think you deserve a standing ovation.
No, not at all. Not at all.
Yeah.
Thank you.
Ma'am, your
very
thank you
much.
slide was amazing. That's our, expert play with images.
You are an AI master also. Once we will have I have been discussing this with Jaya madam. There will be one webinar in which we will have our machines open and madam is going to take nobology for us.
Yeah.
So,
Yeah,
Jaya
my
ma'am,
pleasure. My pleasure.
madam, you know what is the greatest pleasure for a teacher? When the student starts teaching as well as him or her, or even better. So you have proved that today. Though Sonal madam may be your teacher and guru, but you have proved to be so excellent in the mastery of your skills that
Thank you.
madam, you will be an example with which we can quote that there's a great teacher over there in Bhadrachalam.
Ma'am, good evening, ma'am. Bharti, ma'am. I'm the classmate of Pawan and Saroja, ma'am. Happy to meet you, ma'am, in this platform.
Okay. Nice to
Yes,
meet
ma'am.
you. Okay.
So before we sign off, I have the a pleasant duty of introducing our special guest for today, Dr. Shashi Prabha Rokam, ma'am. Ma'am, please unmute. Madam is a very, very senior teacher, mentor, and leader from Andhra Pradesh, Vijayawada. And Madam has been the past DME.
Not Vijayawada, it is Visakhapatnam.
Sorry, Madam. Visakhapatnam. I'm sorry, I'm confused with the cities now. Madam has been the past Director Medical Education and Principal of Andhra Medical College. And Madam is also a mother to one of the finest IVF specialists in the world, Dr. Shesh Kamal Sunkara, who is one of, she's not exactly a friend, but I keep meeting her. And so, ma'am, thank you so much for blessing us. And
Monica, I'm sorry I could not log in the beginning of the webinar. I congratulate you for all these webinars. It is like a postgraduate teaching program as well as for the youngsters also. It will be very useful. And congratulate Jai Bharati madam also.
Thank you, ma'am.
Thank you so much.
Sorry for the delay.
No,
All the
ma'am.
best. All
It's
the best, Monica. All the
And,
best for the
thank you.
elections. We are all there with you.
Thank you, madam.
and all the best also. And our society is going to support you.
Thank you,
And,
madam.
Monica, you didn't send the photograph with my daughter.
Madam, I'm trying to find it in my phone because I was busy with the webinar. I could not do
I
it.
know.
But
So
I will.
I'll be attending your webinars in future also.
Thank
Thank you all.
Thank you so much, madam, for being there. Thank you, Jaya ma'am, and anybody, because Jaya madam has given us such a lot of voluminous talk and messages. So also Sonal ma'am, we have been bound to have missed a little part of it or got diverted or seen a patient or something. So everything is recorded on YouTube and it will be uploaded on YouTube by Dr. Vishal within a couple of hours. And you can please see the link, save the link, subscribe to the channel, and keep watching wonderful, wonderful webinars. In the 3 years of our existence, Synergy has had the privilege of having the best of teachers in India. We are blessed, we are privileged, and we keep asking these teachers for ye dil mange more. So thank you so much. I know I have your blessings, but more than that, I have your love. So thank you so much. And signing off, our next webinar is on 31st of July, Friday. We are dealing with a very exciting topic, obesity. Obesity we'll be dealing with medical management, especially the controversies.
We lost her.
Connection lost.
Yeah. I think you can conclude.
So thank you very much. For it, madam, it was in fact I'm myself a gynecologist and working as a medical advisor to Intas Pharma. So worth
Yes,
listening to your talk.
Yeah,
And
I'm
I
so
know
sorry. Is connected. The topic is obesity. We'll be dealing with medical management of obesity. We'll be dealing with bariatric surgery related to obesity, especially in those women who are going for fertility treatment. And we'll be having a very interesting panel on problems related to obesity in different life stages of a woman, right from adolescence to postmenopause. So watch out for this great session on 31st of July. We have got great speakers, very exciting session, and it is with whole of Tamil Nadu. So thank you so much. Thank you to Team Intas, to my brilliant speaker.
Thank you, Dr. Monica, for
Monica ma'am,
giving me a
thank you,
last
ma'am.
moment chance. Thank you.
Thank you. And I'm thoroughly indebted to Andhra Pradesh and Telangana. I have got so much of love and respect from both these states. I'm indebted to you for all the affection. Thank you so much. Good night.
Right.
Have a
Thank you, ma'am.
keep studying, keep learning.